Hello, my dear friends. Hope you all are fine. Hello, everyone. Very good evening to all of you. Yes, we are just waiting for others to join. There was some technical glitch which has been retrieved and recovered bit up. Let us now go ahead with the session. You all might be eagerly waiting to discuss the 25 most important questions, clinical type questions of biochemistry. Yes. Hello, my dear friends. Hope you all are fine. गोवा से तो फ्री हो गया हूँ. बस 25 मोस्ट इंपॉर्टेंट क्वेश्चंस को निपटाना है अभी. गुड इवनिंग बेटा. गुड इवनिंग एवरीवन. गुड इवनिंग. यस. ओके. गुड इवनिंग. नमस्ते बेटा. नमस्ते. Okay, so let us go ahead with the session beta. All of you are in the process of joining. Let us not waste time because time is crucial and time is very important for our upcoming FMG exam. Okay, let us hit the first important clinical type questions of biochemistry beta. This sort of question did appear in our FMG exam very recently, so let us try to approach and target this question. Read it, no need to rush, we have time. Listen to the question, see the question, look for the keywords, look for the positive findings and try to answer. गोवा के बारे में बात करेंगे, पहले ये सेशन तो हो जाए. ओके, लोग गोवा में ज्यादा इंटरेस्टेड है. जाएंगे, एग्जाम पास होने के बाद जाएंगे, तभी ना मजा ज्यादा आएगा. Yes, my dear friends, all of you are thinking in the right line. Thank you so much for the right answer beta. Yes, this is one of the process that we have discussed. All of you remember that in our discussions we had talked about that safe ammonia transport. आप सबको याद होगा, we have spoken about safe ammonia transport. And in the topic of safe ammonia transport, we had mainly talked about two important things, beta ji. In the safe ammonia transport, please remember beta, we have talked about two important things. Please remember, sorry, yes, two important things. And in this, one of the guy was glutamine and the second guy that was important was known as alanine. Alanine was mainly able to take up all that toxic ammonia in the form of, they were getting converted to alanine itself that was coming from the muscle. However, basically if you look at the last line first, as people say, please remember, the high ammonia formed in the brain is usually detoxified by, so basically the crux of the MCQ is over here, that what is the detoxification from the brain. As we have discussed earlier beta, that almost all the tissues including brain are primarily dependent on this guy that is known as glutamine, because glutamine is the amino acid which is able to trap the ammonia. What happens most of the time, glutamate, my dear friends, traps ammonia. Glutamate joins with one molecule of ammonia and there is an enzyme called as glutamine synthetase, which is an ATP dependent process by which glutamate will be trapping ammonia and it will be converted to a safe amino acid form that is known as glutamine, and glutamine will be able to get carried forward in the blood, that will enter into the liver where it will again release the ammonia back and glutamate will be again regenerated. So this was a question on the chronic liver disease. Non-alcoholic, non-smoker, ALT is quite high, AST is also slightly elevated, ALP is borderline high, plasma ammonia levels found to be quite high because the normal is up to around 30 to 32 millimoles or micromoles per liter beta. So here the significant rise of the ammonia is there, and that's the reason this is a case of hyperammonemia. It is quite evident in patients of chronic liver disease. If they are not able to control their metabolic profile, they might or they soon land into the state of this hyperammonemia, and glutamine is one of the guy that can also help us to get rid of this. Now just a moment. Yes, so this is one of the important things, that glutamine we can take it into account. Please make a note of this beta. Right, this is the safe ammonia transport. We had discussed it earlier that most tissues, let me zoom in, most of the tissues are trapping the toxic ammonia. Whenever the toxic ammonia is released, it will be converted by glutamine synthetase to form glutamine, which is an ATP dependent process. Then via the blood it will be carried towards the liver in this case, and in the liver glutamine again will be converted back to glutamate by the help of enzyme glutaminase, and in this journey it will be able to release that toxic ammonia back, and this ammonia will be now entering into the urea cycle by which it will be detoxified. Please remember, similarly from the skeletal muscle, as discussed with you guys earlier, skeletal muscle का कहानी थोड़ा सा अलग होता है. Here whenever there is release of ammonia, it will be finally trapped by some different mechanisms in the form of this guy alanine. Alanine will be traveling via the blood, it will come back to the liver, where alanine will be undergoing a process called as transamination by the help of amino transferase, that is called as alanine aminotransferase or alanine transaminase, by which alanine himself will be converted to pyruvate, and here glutamate will be regenerated, which will undergo the process of oxidative deamination, by which glutamate, whenever it is converted back to alpha ketoglutarate, during this journey the ammonia will be again released, which will be again converted back to urea. Important take home point from this one extra point beta, as discussed with you guys earlier, this pyruvate usually doesn't like to go for the link reaction. Rather, pyruvate is entering into another biochemical process that is called as gluconeogenesis, by which there will be production of the glucose, and similarly glucose will not be utilized by the liver for ATP production. That's the reason glucose will never ever undergo glycolysis inside the liver. No, pyruvate is converted to glucose, and this glucose is pushed out of the liver. Whenever it is entering into the blood circulation, it will be the reason for survival of the RBCs for longer time, and some amount of those glucose via the blood, whenever they are going back to the skeletal muscle, after going into the skeletal muscle, this glucose now is going to undergo glycolysis. So glycolysis is not seen in the liver in this case, rather it is seen in the skeletal muscle, and this is how, my dear friends, during heavy exercise, whenever the first ATP storage, that is creatine phosphate, second ATP storage, that is muscle glycogen, is depleted, after 10 minutes, my dear friends, the continuous breakdown of the amino acids from the muscle, releasing ammonia, trapping in the form of alanine, alanine converted to pyruvate, pyruvate to glucose, glucose again undergoing glycolysis to generate ATP. This is how beyond 10 minutes, we can go for continuing the heavy exercise. Please try to make a note of this. One more time, very important thing to remember beta. Whenever we are hitting the gym and we are going for the heavy exercise, the first 1 minute of ATP retrieval is done by creatine phosphate. Beyond 1 minute, the switchover is done by muscle glycogen, which is utilized in the muscle itself to generate those 8 ATP, 1 ATP extra that we have discussed. And after that, when 9 to 10 minutes time is gone, then the prolonged exercise is mainly possible by the glycolysis. But that glycolysis, either we have to feed glucose to the patient during the gym, or what will happen inside the skeletal muscle, whenever amino acids are particularly broken down, they can also be utilized further to get converted to glucose, which will now utilized by the skeletal muscle to provide ATP itself. This is how beyond 10 minutes we can go for prolonging the exercise, and this is one of the mechanisms that is also important in case of marathon runners or the long distance runners. Please try to understand. You will see always long distance or marathon runners are actually quite lean and thin. They are not having big bulky muscles. No, they are always lean and thin. Why? Because marathon runners, they need to run for longer time, and if you want to run for longer time, then what will happen? There is a chance of muscle breakdown also within your body, because the muscle proteins are utilized to release muscle amino acids, which are further broken down, and ultimately alanine, glucose, glycolysis, this story will go on. So there is a continuous muscle protein breakdown going on in marathon runners. That's why they can run for longer time. So different type of mechanisms, sprinters, marathon runners, that we have discussed during the classes. And please remember, inside this glucose, alanine, glucose, this cyclical movement that is happening, my dear friends, all of you have understood this. Please remember beta, this is also known as the famous Cahill cycle. This is also another question that has been asked in your FMGE exam beta. Cody cycle is different, Cahill cycle is different. Cody cycle is concerned with the lactate conversion, whereas Cahill cycle is concerned with the alanine's conversion back to glucose. Yes, alanine to glucose through pyruvate. Pyruvate is undergoing glucose by the process of gluconeogenesis. But whenever this recycling is happening between two different organs, liver, muscle, muscle, liver, this cyclical movements, the alanine transport is actually also called as Cahill cycle. This is one of the important questions that we have to also keep it in our mind, beta. Please remember this. Okay. So I hope this sort of question, whenever it is asked, you will be able to happily tackle this definitely. Okay, second question, beta. Take some time and try to understand this. Don't jump the gun. See the question properly and then you please answer, beta. आराम से देखिए, then answer. Is a bit tricky question, but if you remember the workbook pages where we have discussed about alcohol metabolism, in that alcohol metabolism topic we did discuss about this compound. Shalav, you need to rethink, beta. Yes, Vipul, Vavishya, yes, my dear friends, now all of you are actually coming up with the right answer. First of all, let me mark the right answer over here, beta. The right answer of this question is actually acetaldehyde. This is the right answer of this question, beta. Acetaldehyde. Now, what happens in case of alcohol metabolism? Let us try to remember this. This is a basically question of substance abuse. Basically, she is undergoing those treatment for abstinence, alcohol withdrawal is hitting her. These are the things, some drugs might have been given, alcohol withdrawal. Okay, now what happens? Please remember, all of us know, let us revise quickly, beta. As we know that whenever we drink alcohol, alcohol will be converted to a guy that is known as acetaldehyde. Alcohol will be converted to acetaldehyde. This conversion is done by that enzyme ethanol dehydrogenase. Alcohol will be converted to acetaldehyde, and this acetaldehyde, further as discussed with you guys earlier, it is converted to acetic acid. Name of this enzyme is called as aldehyde dehydrogenase. This was ethanol dehydrogenase for the first step. This is the aldehyde dehydrogenase for the second step. And this acetic acid, which is a mild acid, by some chemical reaction later on gradually, it can be also converted to acetyl CoA. This is the reaction, my dear friends, that can be continued. And this we had also linked up with the pyruvate lactate conversion, because whenever this conversion is taking place, we have also discussed that this NAD plus will be used up, and that will go for overproduction of the NADH plus H plus, right? We have also discussed this कि NAD से NADH plus H plus का production वगैरह बढ़ जाता है. Now what we have to remember, please remember, whenever a patient of chronic alcoholism is given some drug, they are actually trying to hit with this particular. So what is the question? When the patient is, as a first attempt to curb the patient's drinking, she is given a drug that will lead to the elevation of which one of the following? See, please remember, whenever we drink alcohol, all those hangover and all those symptoms that appear in us, this is the guy which is the culprit compound for those hangover that we get to see in after alcohol consumption. But when the patient is on drug, and please remember, suddenly this acetaldehyde production will be increased too much, and that will actually have a negative impact on the consumption of the alcohol further, and that particular person will not like to drink alcohol anymore. So look at the question. This is the main important point. As a first attempt to curb the patient's drinking, she is given a drug that will lead to an elevation. Yes, that lead to an elevation of which one of the following metabolized if she drink alcohol. So when she is already on the drug, जब दवाई दिया जा रहा है उस वक्त अगर उसने दारू पिया, If she is drinking along with the taking the drug, then there will be sudden upshoot of this dangerous compound that is known as the acetaldehyde, and she will have a very peculiar type of symptoms and she will not feel like to drink alcohol anymore. So this is the question that we have to remember over here, beta. Yes, fomepizole that we can also give in these cases. So during the drug, whenever it is given, the patient must refrain from taking the alcohol. Just for your note, after the session, as I will also share you the PDF over here, beta. So I have given you some idea. Let us quickly read it, beta. As we have discussed, one treatment for chronic alcoholism is to inhibit that enzyme aldehyde dehydrogenase. What is that enzyme? First enzyme or the second enzyme? It is the second enzyme. I am talking about this enzyme, beta. Aldehyde dehydrogenase. Aldehyde dehydrogenase. So one treatment for chronic alcoholism is to inhibit the enzyme aldehyde dehydrogenase, which would lead to the accumulation of acetaldehyde if ethanol has been taken up. Now, ethanol metabolism, the first step we already know, as it is converted to acetaldehyde. Enzyme is the alcohol dehydrogenase, which is known as EDH or the ethanol dehydrogenase. Aldehyde dehydrogenase then convert the acetaldehyde to acetic acid, which is eventually converted to acetyl CoA. We have seen that pathway just now. Now, the accumulation of acetaldehyde is what initiates all the symptoms associated with a hangover, such as headache or sometimes also vomiting type of tendencies if they try to drink too much of alcohol. So the culprit compound in our story that we have to keep it in our mind is this guy, that is acetaldehyde. Acetaldehyde is the culprit compound over here. And please remember, during the treatment, if the individual drinks alcohol while on the drug, the buildup of acetaldehyde will make the person feel very uncomfortable, and that will lead to a reduction, cessation, or the drinking of alcohol. Because whenever she is on drug, if she drinks alcohol, rather than getting the kick, she will be getting, or he will be getting, a different type of sensation, and that would be not well tolerated by the patients. Please try to understand. The other things are not associated over here that I have already written. You can read whenever you are free. So this is the question on this alcohol abuse. Please try to make a note of this. Other three are not the one. Acetaldehyde is the answer of this question. Okay, coming to the third question. This is an easy one. Let us try to quickly see this. By looking at the first line, probably you all will be able to guess it correctly. Mixed answers are coming. Some of you are going for the option C, some of you are going for the option B. But this is a straightforward question. I really pray that all of you can come out correct on that exam day with this direct question. But देखो, directly it is telling us, see, there is an fracture humerus sustained to be minor trauma, fracture of long bones. Please try to understand. Minor, multiple fractures, minor trauma. Please remember, sky blue sclera and AR type of murmur, aortic regurgitation murmur. This question, my dear friend, what is the diagnosis? All of you are thinking on the right diagnosis, beta. This is osteogenesis imperfecta. This is the plain and simple diagnosis over here. And please remember, in osteogenesis imperfecta, we all know it is mainly due to the type 1 collagen defect. This is due to the type 1 collagen defect. Please remember, we have also discussed in osteogenesis imperfecta, there are three main type of gene mutation: 1A1, 1A2, 1A3 and 1A4. Total 4 types of gene mutations are there. In India, we see only up to 1A3. However, outside India, 1A4 is also possible. However, out of all these gene mutation, if it is asked in your FMGE exam as a question, please choose collagen 1A1 gene mutation as the best possible answer. But the most common gene mutation leading to Y is कोलाजन 1A1 जीन म्यूटेशन आप सबको याद होगा. वी हैव डिस्कस्ड अबाउट द मेजर क्लिनिकल फीचर्स that frequent fractures with minor trauma, and these are self-healing type of fractures, usually doesn't require any active management, no open reduction, internal fixation, no K-wire, no nail, no mesh, nothing, no splint, no cast, no supports are required. Fractures will be there and heal by itself. Blue sclera, kyphus scoliosis, bowing of legs and hands, deformed teeth formation. We have talked about barrel-like chest also. Barrel-like chest. Those are the features of the osteogenesis imperfecta. Please remember here the answer of this question. All of you by now would have guessed. The right answer will be beta. It is the type 1 collagen mutation. Type 1. Type 4 collagen. My dear friends, type 4 collagen leads to a disorder that is known as our Alport syndrome. Type 4 leads to Alport syndrome. Alport syndrome. Can't see, can't hear, can't pee properly. सुन नहीं सकता, देख नहीं सकता, नहीं कर सकता. Please try to understand. We have talked about those. Can't see, can't hear, can't pee properly. Now, fibrillin 1 gene mutation. All of you are familiar with this Marfan syndrome, beta. Fibrillin 1 gene. All of you know Marfan syndrome. And alpha 1 antitrypsin. It leads to emphysema. In physiology as well as in medicine, all of you must have heard about this emphysema. Emphysema and atelectasis are two different things. Atelectasis is mainly the collapse of the lungs. That is a different thing. Emphysema is different. Please try to remember better. So these are the 4 different things that we have to remember beta. Yes, all of you are thinking in the right line. Please remember. Apart from what we have discussed in our classes, if you remember this radiographic that I told you earlier, it was asked as a question in your exam. What is the shape of this chest wall? It is looking like barrel-like chest. Barrel-like chest. Please remember, sometimes they might ask you, look at this particular child. Look at this particular child. This type of faces that we are also seeing over here. Please remember, like a triangle. Please remember, triangular face. Sometimes people try to call it as triangular faces. Trikon jaisa. Triangular faces is also seen in case of osteogenesis imperfecta. This image cluster is mainly for osteogenesis imperfecta beta. Face like a triangle, triangular faces is one of the important things that we need to remember. Pink puffer, yes. Marfan, yeah, Marfan syndrome that we have discussed earlier. With triangular faces, please remember, triangular faces and barrel-like chest. These are the 2 important things we have to take a call. Okay. Fourth question. Fourth question. थोड़ा सा टफ क्वेश्चन हो गया क्या? Is it a bit tough? आराम से. First of all, tell me the diagnosis. Leave the question. First of all, please tell me the diagnosis. What is the diagnosis? Yes, right answers. Right answers. All of you are thinking in the right answer, better. Yes, the diagnosis over here is Alport syndrome. बिल्कुल सही. सही जवाब. Alport syndrome is the diagnosis over here. It is a late onset. See, Alport syndrome, it is not always that in the teenage group only it will be seen. It might be a late onset because the inheritance pattern of this Alport syndrome, it is mainly X-linked recessive, but sometimes it can be also of dominant type as well, autosomal dominant type as well. These are the different varieties. So there can be a late onset. It is a case of plain and simple Alport syndrome. What are the things which are matching over here? Let us quickly see this better. Large amount of blood is hematuria as well as proteinuria. First sign I told you is hematuria, but it can lead to proteinuria if the GBM is defective so much. We have talked about that basket weave type of appearance in the glomerular basement membrane where the type 4 collagen is mutated. Then apart from that, also the positive findings are which one? SNHL, sensory neural hearing loss. And please remember misshaped lens, anterior lenticonus we have also discussed. Even if this extra hint that I have given you, it might not be given on the exam day beta, but please try to remember beta, misshaped lens if it is given, we can also try to think about that. It can be posterior lenticonus in some other disorder, but in this case of Alport syndrome, A4A, I told you anterior lenticonus. And ultimately if it is not treated on time, it can lead to also ESRD, that is the end stage renal disease, where kidney transplantation will be the only possible type of treatment that might be required. So Alport syndrome patients should be taken care as early as possible. And basically they have asked a question on the gene mutation beta. It is due to the type 4 collagen defect. Out of all these options, you are seeing only in the option number B, it is telling us that it is the collagen 4A5. Please remember, Alport syndrome, for your knowledge, Alport syndrome basically can be due to three type of gene mutation. This is collagen 4A3, 4A4, 4A5 gene mutation. And please try to remember, if it is a late onset, type of Alport syndrome, most of the time it is due to 4A5. Overall, if somebody asks you overall also, please try to remember, it is one of the safest answer that 4A5 gene mutation we can also mark it over here. Like in case of osteogenesis imperfecta, it is collagen 1A1. In case of Alport syndrome, it is the 4A5. Ehlers-Danlos syndrome, it is collagen 5A1 type of gene mutation. Most common collagen defect was the type 5 type of collagen. Please remember. Okay, what about the other options? Yes, I will definitely try to help you beta. Let us quickly note it down beta, these important points. Spectrin, please remember, if there is a gene mutation due to problems in the spectrin, then we have another disorder called as hereditary spherocytosis. Fibrillin 1 gene mutation, Marfan syndrome. Acha, what about this guy, beta myosin heavy chains? Please remember, if this is mutated, then we have a disorder called as FHC. What is FHC? Familial hypertrophic cardiomyopathy. Familial hypertrophic cardiomyopathy, it is due to the beta myosin heavy chain mutation. Now please remember, under this FHC only, you must have heard about something known as HCM type of disorder. HCM is nothing but hypertrophic cardiomyopathy, which is under a spectrum of disorder called as FHC. FHC is a broad term. HCM, it is a miniaturized term. HCM. And you must have heard about also another type of problem that is known as HOCM, hypertrophic obstructive cardiomyopathy. Please try to understand, this HOCM is actually coming under the list of the disorder called as HCM. So all HOCMs are actually a type of HCM, but all HCMs are not exactly as HOCM. If it is cardiomyopathy due to the obstruction, wherever the obstruction is caused at the left ventricle due to hypertrophy, if the blood is not able to pump out from the ventricles properly on the echocardiography, if the ejection fraction decreases, then it is called as HOCM. But there are other type of disorders where there is hypertrophic cardiomyopathy without any obstruction as well. But all of these are actually under a large group of disorders which are called as FHC, which is called as familial hypertrophic cardiomyopathy. Please try to make a note of this. This we did not discuss during the classes. You might have heard about this in medicine, but in case if you have not heard, please remember. And this HOCM is one of the very important type of diagnosis whenever athletes are suddenly succumbing to death during the matches. Suddenly somebody is having an heart attack during the match, or athletes or any heavyweight person is trying to do the gym and suddenly they collapse in the gym. Most of the time it might be due to HOCM, hypertrophic obstructive cardiomyopathy. And in all these cases we can choose the answer possible over here as the mutation of beta myosin heavy chains. Beta myosin heavy chains, please try to make a note of this important point. Try to make a note of this. HOCM के बारे में पढ़ लेना, this is important बेटा. Yes, hereditary spherocytosis is due to spectrin mutation, and these are the other two. I just thought about Sherry. Please remember, athlete sudden death, gym going person sudden death, most of the time it might be due to HOCM, hypertrophic obstructive cardiomyopathy. What happens at that portion from where the blood actually is pumped out, there the left ventricular valve will be actually undergoing hypertrophy in such a way so that the blood is not able to pump out towards the aorta properly. That's the main problem in case of HOCM. Okay. In Alport syndrome, let us try to quickly remember one of the important thing, although we did not discuss Alport syndrome in detail, but we have discussed at least can't see, can't hear, can't pee properly. Actually, the full mnemonic of Alport, as discussed with you, it is Alport. See, from that alphabet A, we are having four things over here. Looks like four. A looking like four things. First of all, it is the type 4 collagen defect. And in the type 4 collagen defect, most common I told you is 4A5. What is the A stands for? Alpha. Alpha 5. 4A5 is the most common type of gene mutation which leads to Alport syndrome. Please remember, and one of the things that we can prescribe in these patients, whether early or late, we can give them enalapril or the AC inhibitor. Sometimes we also give them the antihypertensives to reduce the renal damage and disease progression. Then from the 4, please remember, it is hereditary importance. I told you also runs in the families. That's why hereditary looks like this. And please remember, it is actually X-linked. Please remember, this is actually X-linked type of disorders. Mainly we have to remember, most common type of, it is not autosomal, it is the X-linked type of disorder where it is more common in the male rather than female. Type 4 collagen, it is present in the glomerular basement membrane as well as lens as well as cochlea. This is directly from the note that we have discussed beta. Lens related defects are there. What is that? Anterior lenticonus. I told you anterior lenticonus is more commonly seen than posterior lenticonus. That's the reason these patients also will have, please remember, nearsightedness. What is the nearsightedness? Also called as myopia. Apart from that, please try to understand that hearing defect, SNHL, sensorineural hearing loss, glomerular basement membrane, there is a thinning, and this GBM is classically having the basket weave appearance. And if it is not treated properly on the time beta, it can be sclerosed and fibrosed, and in such cases ultimately end stage renal disease is the outcome. And if the patient by chance reaches to that, then the ultimate mainstay of treatment will be the transplantation. T for transplantation, R for renal problems that we have also had, proteinuria and the renal problems. So these are the things from the Alport syndrome that we have to keep it in our mind better. Please try to make a note of this Alport syndrome, type 4 collagen defect. Okay, question number 5. Expected question. All of you should come out with correct answer. This is actually a bouncer. I knew both the answers will come. B also will come, D also will come. I knew this is a bouncer. This is a bouncer, beta. Please remember, all of you know, by looking at the history, all of you know that what is this poisoning? What is the diagnosis? Hello, what is the diagnosis? What is the diagnosis? Carbon monoxide poisoning. आ गया diagnosis. The diagnosis is carbon monoxide poisoning. In case of carbon monoxide poisoning, many of you are answering the question as D, but first of all, let me tell you the answer of this question. The answer of this question is this. It is a bouncer. Don't panic. Don't panic. That's the reason we are discussing together. Don't panic. Correct answer is B for this question. decreased oxygen delivery to the tissue. Let us go a little bit step by step what happens. All of us know carbon monoxide has got 230 times more affinity towards hemoglobin as compared to oxygen, and in presence of both, carbon monoxide will displace the oxygen and he will go and capture the hemoglobin, and it will form a stable complex called as carboxyhemoglobin, right? So it feels like carbon monoxide is decreasing the oxygen affinity to hemoglobin. No, try to understand one more time. Carbon monoxide himself has got 230 times more affinity towards hemoglobin than oxygen, right? But that does not mean carbon monoxide is decreasing the oxygen's affinity to hemoglobin. No, he is having more power, he is capturing the hemoglobin, okay, but it is not stopping the oxygen to bind with the hemoglobin. Try to understand. It is a type of reversible component type of inhibition. Try to understand the funda. If you go by the option number D, then we can never ever use oxygen as the treatment of choice. I told you during the classes, what is the treatment of choice? Hyperbaric oxygen therapy, 100% oxygen, high flow, mass 6 to 7 hours. If you give oxygen and you are telling that oxygen's affinity to hemoglobin is low, then how the hell oxygen can be used as a treatment? So that is not the case. Try to understand better. Carbon monoxide has got more affinity, but it does not decrease the affinity of oxygen towards hemoglobin. No, दो धारी तलवार यहाँ पर नहीं है. He is only one way of acting. He is displacing oxygen so that he himself can go and bind with the hemoglobin over here. Try to understand the catch. That's why it is a tough question. It is a tough question. Try to understand better. Now, what happens? That's why I have written you clearly. Let us try to see the explanation. This will help you on that exam day. It is a case of carbon monoxide poisoning. Carbon monoxide will bind to hemoglobin with a high affinity than oxygen and decreases oxygen delivery to the tissues. Okay. ये ऑक्सीजन को टिश्यूज तक पहुंचने नहीं दे रहा है बिकॉज हीमोग्लोबिन इज नो लॉन्गर फ्री टू बाइंड विद द ऑक्सीजन बट एफिनिटी इज स्टिल देयर. That's why if you increase the oxygen concentration in our body, then we can also stop the carbon monoxide from capturing the hemoglobin. That's how we can use oxygen as a treatment of choice. Try to understand. In addition to competing with the oxygen for binding to hemoglobin, carbon monoxide, once bound to hemoglobin, shift the oxygen curve to the left side. All of you know, because it is going to hold on to the hemoglobin. Tight binding, R state, इसको कभी कभी लोग टॉट स्टेट भी बोलते हैं, टॉट स्टेट or oxygenated state, which makes it more difficult for the oxygen to be released from the hemoglobin in the tissue. Thus, in the presence of carbon monoxide, oxygen affinity for the hemoglobin is actually increased, not decreased. बेटा टाइम क्यों मिलता है? Why carbon monoxide is a slow poisoning? Because oxygen is still somehow doing its job. It is being beaten by somebody else who is more powerful, but his affinity towards the hemoglobin is actually increased. It is actually the double-edged sword, not like that beta over here. It is a different type of scenario. And carbon monoxide poisoning does not affect the blood flow to the brain. That has got no relation. But this is the important light I am highlighting so that whenever you are actually revising this from the notes, it will help you. Please remember, oxygen binding curve shift to the left. Oxygen binding oxygen hemoglobin distance curve shifting to the left means oxygen and hemoglobin, whatever is available over there, they are somehow tightly bonded. Somehow they are trying to keep you alive, and it is the oxygenated state which makes it more difficult for the oxygen to be released from the hemoglobin in the tissue. वो टिश्यू में ऑक्सीजन डिलीवर नहीं हो पा रहा है. The tissue is not able to get the oxygen because hemoglobin is capturing the oxygen in a very tough or taut state. That's why this is called as oxygenated state for the hemoglobin. Thus, in the presence of carbon monoxide, oxygen affinity for the hemoglobin is actually increased. But there is a but over here. But oxygen is not released at the peripheral tissue level. This is a tough question. Please try to remember better. Decreased oxygen delivery to the tissue, and this is not the answer. This is not the answer, because it should be increased oxygen affinity for the hemoglobin. Something's new that we have learned over here. Please try to understand. Important point. Please make a note of this. Some motivation which is needed for all of us. Some of you are saying difficult to remember. I totally understand, beta. 5 long years over there. If you have already done internship, then 6 years of journey. You guys did not even get properly 5 months time for preparing all the 19 subjects. Sometimes it feels like, how will I do it? It is not possible. You get disheartened, but that is not the case, beta. Many of your seniors have got the similar amount of time, and they have all scored and passed FMG exam with flying colors, and my belief is there that all of you will be able to also do same or probably better than them. So my dear friends, gradual stepwise manner, stepwise ladder, ultimately it is going to take you till the success. From the moment you landed in a foreign soil almost 5 6 years back, all of you probably had only one goal, that after 6 7 years down the line, once I go back to my own country, I will be able to crack that licensing exam, and you will metamorphose from an FMG to an IMG. That is the goal, that is the success that all of we are praying from our core of the heart, beta. Please keep pushing yourself, and ultimately on 28th of June, once you are done with the exam, I believe definitely you would have done enough to crack the exam in the very upcoming attempt itself, beta. Praying for all of you from the core of my heart. नेक्स्ट क्वेश्चन, पैथोलॉजिस्ट है, कुणाल सर बुरा मान जाएंगे, कुणाल सर के ऊपर डेडिकेटेड नहीं है ये क्वेश्चन, पढ़ो आराम से. Thank you, Navid. Thank you so much. Wish you many more successes in your life, beta. Arshad, thank you so much, beta. Wish you again many more successes in your upcoming life, beta. Sky is the limit. Thank you so much, Pallavi. Thank you so much for your golden words. It will definitely help this existing batch to also pass with flying colors. Thank you for those golden words, beta. Really means a lot to us. Thank you so much. All of you have done right in this question. Straightforward question. It is a case of Prion disease, Creutzfeldt-Jakob disease. Accidentally cuts himself during the autopsy. There is a chance of transmission. I told you, even it is very, very difficult to kill these prions even after incineration as well. So just imagine what will happen if you come in direct contact by cut injuries. Not a deadly virus. These are actually proteins. And what type of proteins? These are misfolded proteins. What is the misfolding? In the secondary structure, alpha helices are exactly okay, but the beta pleated sheets are getting damaged. The sheet like folded patterns are lost. That's the reason these misfolded proteins are going to get deposited in different parts of the brain, primarily cerebral cortex, cerebellum, thalamus, like these areas, and it can cause some neurological symptoms, and in worst cases like Creutzfeldt-Jakob disease, it can also kill the patient if the amount of toxic prion that has been ingested or gone into the body are quite huge in number. So this is the answer. All of you have done right, beta. Misfolded beta plated sheets in the protein, toxic proteins which are coming from the outside. Very, very ultra cautious people has to be, because it can lead to mass disasters as well. Just like the time of corona, we were trying to take all the precaution, mask, glasses, extra face shield that we were using. Basically during the autopsy, the forensic specialists are also going to take the same amount of precautions if the patient had died due to prion disease. During those PG exams questions, whenever, my dear friends, you are facing some unknown question, we have to keep it in mind, in our mind, that whatever the first thing that strikes in our mind, that is mostly going to be the answer. Bhagwan ka naam leke, please try to mark that as the answer, and most of the time that will be the right answer on the tough exams as well, beta. Thank you, Sakshi. for your golden words beta, really means a lot to me. Yes, बिल्कुल सही जवाब. Meanwhile, all of you have got the right answer. See, basically, the answer of this from the graph, I believe all of you would have got this particularly picked up from the graph easily. Doesn't cross but meet, doesn't cross but meet, that was the fund I told you. Crosses but doesn't meet, competitive, doesn't cross but meet at a common point, it is going to be non-competitive type of inhibition. Acha, what is this drug I'm talking about? What is the drug? What is the drug? नीट पीजी का बैच तो हम लोग स्टार्ट ही कर रहे हैं बेटा फ्रॉम दिस अपकमिंग जून जुलाई. सो प्लीज फील फ्री टू जॉइन अस. विल ट्राई आवर बेस्ट टू गिव यू द your desired seat that you would have aimed for PG level exams as well. From the entire team of MIST, yes, we will be also going ahead with the NEET PG, because many of you who have passed out from us have requested us that you want to go ahead with our teaching so that it can be beneficial for you even in your post graduation entrance exams as well beta. Yes, अभी स्टार्ट करके अभी ठीक करके देंगे, कोई प्रॉब्लम नहीं है. नेक्स्ट टाइम के लिए फॉर पीपल हु आर गोइंग टू ऑप्ट फॉर 2027 नीट पीजी, प्लीज फील फ्री टू जॉइन अस and we will try to help you out in your future endeavors as well beta. Most likely the batch will start from the late June or the early beginning of the July, and let us hope for the best that we will be able to help you. अच्छा, what is the drug? अरे कहाँ चला गए? अरे ये सब तो चला ठीक है. What is the drug I was talking about? अरे hello रे, skiing, Rockies, medication, combat, altitude sickness. Ah, what is the drug people would have taken beta? Medication. What is that medication? All of you know the name of the drug is acetazolamide. Acetazolamide. एट्रोपिन नहीं रे, है ऑल्टीट्यूड सिकनेस एट्रोपिन. ए नो नो, हेलो हेलो, नो नो नो, व्हाट इज द क्वेश्चन दैट आई एम आस्किंग ओवर हियर? नहीं, लिटिल रास्कल यहां पर कहां से आ गया? एसिटाजोलामाइड, वी आर डिस्कसिंग अबाउट बेटा एसिटाजोलामाइड ओवर हियर. प्लीज रिमेंबर, नहीं रे स्टैटिन, कहां से कहां चले जा रहे हो? हेलो हेलो, फोकस फोकस फोकस. non-competitive over here drug that we try to give for acute mountain sickness. Hello, AMS, acute mountain sickness. What is the drug we try to give it to the patient? Acetazolamide. All of you know it is a carbonic anhydrase inhibitor, non-competitive type of inhibitor, acetazolamide. अरे बाबा रे बाबा, तेल से तेल अभी कैसे लाएंगे? बाप रे. आगे बढ़ते हैं. एसिटाजोलामाइड, carbonic anhydrase inhibitor. Usually whenever there is a people are going for high altitude mountain passes, climb high but take risk little lower, people always say that because of acclimatization. As soon as you want to, if you are tomorrow morning you are planning for high altitude mountain passes, at least one night before that you are advised to particularly take this sort of acetazolamide so that the ventilation perfusion can be maintained over here. It doesn't allow the bicarbonate to properly break down because it is an enzyme blocker, that is the carbonic anhydrase, CO2 plus H2O carbonic acid, which further disassociates into H plus plus HCO3 minus. It is a blocker of that. Okay, next question. हाई ऑल्टीट्यूड माउंटेन सिकनेस, एसिटाजोलामाइड. एसिटाजोलामाइड से क्वेश्चन आया हुआ है, डोंट फॉरगेट दैट. एक्यूट माउंटेन सिकनेस, प्लीज डू कैरी इट इफ यू आर प्लानिंग ए ट्रिप टू लद्दाख. गोवा के साथ साथ लद्दाख जाना भी इक्वली इंपॉर्टेंट है, मैंने सिखाया है. ओके, आगे बढ़ते हैं. क्वेश्चन नंबर 8, आंसर. हेलो, व्हाट इज दिस? व्हाट इज द डायग्नोसिस? अच्छा चलो, सी 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 सी, सब लोगों ने बोल दिया सी 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 इज द राइट आंसर. डिफेक्टिव हाइड्रोक्सिलेशन ऑफ प्रोलीन एंड लाइसिन. व्हाट इज द केस? स्कर्वी. यस, ऑल ऑफ यू आर थिंकिंग इन द राइट लाइन बेटा. द केस ओवर हियर is scurvy, and in scurvy we know it is the primary structure of the collagen which is unable to get converted to secondary structure because there is a failure of hydroxylation of both proline and lysine. Prolyl hydroxylase, lysyl hydroxylase, these are the two enzymes which are dependent on vitamin C. Please remember, bleeding gums, by which some teeth falling off. I told you falling off of teeth, tooth loss is also possible. Red spots, on the tight thighs and the legs, this is called as beta petechial hemorrhages. This is called as petechial hemorrhage. Okay, I'm asking you one more question. What is the other name of petechial hemorrhage? What is the other name of petechial hemorrhage? पेटिचियल अगर वर्ड नहीं दिया, इसको आप लोग बोलते हो पिन पॉइंट हेमरेज. पिन पॉइंट प्यूपिल दूसरा चीज होता है, पिन पॉइंट हेमरेज यहां पर है. इज देयर एनी थर्ड नेम? इज देयर एनी थर्ड नेम? सब लोग कहां गए, सो रहे हैं क्या? अरे आईपीएल तो देखने नहीं बैठ गए, क्या कर रहे हो? अरे बाबा रे, अरे बाबा. एकाइमोसिस इज डिफरेंट बेटा. एकाइमोसिस में ऐसे छोटे छोटे स्पॉट्स नहीं आते. एकाइमोसिस इज ए डिफ्यूज्ड वन, जिसको ब्रूजिंग भी बोलते हैं. एकाइमोसिस, ब्रूजिंग आर ऑलमोस्ट सिनोनिमस. दिस इज डिफरेंट. पिन पॉइंट, इफ यू गो क्लोज टू द स्किन देन ओनली यू विल बी एबल टू विजुअलाइज इट. फ्रॉम ए डिस्टेंस इट लुक्स नॉर्मल. पिटिचियल, पिन पॉइंट हेमरेजेस. ना परप्यूरा तो डिफरेंट. इडियोपैथिक थ्रोम्बोसाइट. आईटीपी तो दूसरा चीज हो गया, परप्यूरा. प्लीज रिमेंबर बेटा, ये पेटिचियल पिन पॉइंट के साथ साथ और एक नाम भी होता है इसका, जिसको हम लोग बोलते हैं पेरीफॉलिक्यूलर. पेरीफॉलिक्यूलर हेमरेज. बेसिकली हेयर के एंड्स के चारों ओर, प्लीज रिमेंबर, एट द ओरिजिन फ्रॉम एन हेयर फॉलिकल, अराउंड दैट हेयर फॉलिकल, पेरीफॉलिक्यूलर हेमरेजेस आर द पिन पॉइंट. तीनों ही देखो पी है. ऑल थ्री आर पी. पेटिचियल बोल सकता है, पिन पॉइंट हेमरेज बोल सकता है. दे कैन ऑल्सो यूज द वर्ड एज पेरीफॉलिक्यूलर हेमरेज. प्लीज रिमेंबर, ऑल दिस थ्री आर सेम. All these three are same, but please try to make a note of this beta. Perifollicular hemorrhage has been recently asked in NEET PG questions as well beta. Petechial hemorrhage, pinpoint hemorrhage, perifollicular hemorrhage, all these are same. Try to understand same thing. Three different type of names. Okay, insulin inadequate, iron intake no. Hemoglobin के साथ ये सब relationship नहीं है. Iron deficiency no. Insulin synthesis no. Not really feature of diabetes. No Marfan syndrome. No Marfan syndrome over here. Okay. Read the question, then answer. Read the question, then answer. ग्लाइकोलाइसिस फर्स्ट स्टेप से क्वेश्चन आ गया. ओ माय गॉड. आराम से. नो नीड टू रश. टेक ए डीप ब्रेथ. रीड. Right answer. Most of you have answered it correctly beta. All of you have understood the topic of km. Thank you so much. Feels very happy for all of you beta that you have understood the tough topic of km. Michael is maintained constant. Please remember, look at the question. Right answer is B. Right answer is B. Yes, all of you have done it right. Now question, km value is how much? 7 millimoles. Great. Blood glucose is 5 millimole under fasting, obviously कम होगा, and it rises in the liver to 20 millimole after a carbohydrate rich meal. Okay, now if a person who is fasting eats a high carb meal, the velocity of the glucokinase reaction will change in which of the following ways? See, his km value is 7. That means to cross that barrier of Vmax by 2, that was the checkpoint in that substrate velocity, that hyperbolic curve that we were discussing. Please remember, that point number B that we had discussed, point number B was the checkpoint. That was the minimum barrier, minimum checkpoint that we need to cross, so that with the same amount of substrate we can go to the point number C and achieve Vmax. थोड़ा सा मन में याद करो, हमने को ने बात किया था zone A, B, C, D. Zone B was the main barrier. I told you B for barrier. Zone B was the checkpoint. If we can cross, then the job is done. You have to just allow some more time, and ultimately we will be able to reach to the top speed or the Vmax of the reaction beta. And what happens to break that barrier? We need to go from below Vmax by 2 to above Vmax by 2, because Vmax by 2 is the checkpoint. That is Km substrate at Vmax by 2. If we can cross that, then the job is done. That means just below the Vmax by 2, you are going above Vmax by 2. Just below 50%, half of Vmax, to more than 50%, more than half of Vmax. If we can breach that barrier, the job is done, and ultimately the reaction will be possible. So in a postprandial state in the liver, whenever glucokinase is working, the glucose level should be high, because the Km value of glucokinase is higher as compared to the Km value of hexokinase 2, which is present in the muscle. Please try to remember, this is the straightforward question. Vmax by 2 को हम लोग breach कर रहे हैं. This sort of technical questions can come in our upcoming FMGE exam as well. Your concept has to be very, very strong over here, beta. Thank you so much for your kind words, beta. Let us move to question number 10. आराम से, वेरी इजी क्वेश्चन. 2 बार क्वेश्चन को पढ़ोगे आंसर आ जाएगा. स्ट्रेट फॉरवर्ड क्वेश्चन, कॉन्सेप्चुअल क्वेश्चन. बेटा क्वेश्चन को दोबारा पढ़ो प्लीज प्लीज प्लीज. व्हाट इज द वर्ड यू ऑल आर मिसिंग? कौन सा चीज छूट रहा है? हेलो हेलो हेलो, व्हाट इज द वर्ड यू आर मिसिंग? दिस इज द वर्ड यू हैव ओवरलुक्ड. ये मिस हुआ है, ध्यान से पढ़िए, ध्यान से पढ़िए. दिस इज द वर्ड लीस्ट लाइकली. अरे बाबा रे, लीस्ट लाइकली टू प्रोवाइड. अभी आंसर लीस्ट लाइकली टू प्रोवाइड नाउ. यस, फ्यू ऑफ यू हैव आंसर्ड इट करेक्टली बेटा. अरे देखो 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 देखो, ओके ओके ओके, ये सब स्टारवेशन के बारे में बात चल रहा है, राइट? इट इज ए क्वेश्चन दैट इज गोइंग ऑन स्टारवेशन. फर्स्ट ऑफ ऑल क्वेश्चन क्या है? व्हिच ऑफ द फॉलोइंग फ्यूल स्टोर्स लीस्ट लाइकली टू प्रोवाइड सिग्निफिकेंट कैलोरी. कैलोरी मतलब एनर्जी. Which of the following is least likely to provide energy? Adipose tissue TAG, adipose tissue TAG, triacyl glycerol breakdown. How it is done? We have discussed about hormone sensitive lipase. Hormone sensitive lipase will target the TAG, DAG, MAG. ऐसे होते होते long chain fatty acids will be given out, and ultimately those will be carried by albumin, Z protein that will go to the site of beta oxidation. So this finally will go for beta oxidation, and beta oxidation तुम्हें भर भर के beta oxidation will give you very 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 huge amount of ATP. So you will get ATP by adipose tissue TAG breakdown. Muscle glycogen, muscle glycogen, glycogenolysis. I told you 8 ATP. Remember, मसल ग्लाइकोजन जब टूटता है, वी गेट 8 एटीपी एक्स्ट्रा बेनिफिट. एडिपोज टिश्यू ट्राइएसाइल ग्लिसरॉल इज देयर एज एन ऑप्शन, बट माय डियर फ्रेंड्स, इफ यू लुक एट द ऑप्शन नंबर बी, liver glycogen, what is the fate of that? During starvation, liver glycogen breaks by liver glycogenolysis, but the reaction is coming back till glucose, and the glucose is not going for glycolysis in the liver, rather it is given out to maintain normoglycemia for 18 long hours for the survival of the RBCs and the brain. So who is the guy that is least likely to provide ATP? It is the liver glycogen, because his focus is to generate glucose. Please remember, that's why in this question liver glycogen is the best possible answer that we can make a note of this. Least likely may you will go for option number B, liver glycogen. Yes, partly this option number D is also correct, but as this guy is there, adipose tissue triacylglycerol, that's why we are not picking up that answer. Please try to remember zone option number B will be the right. It is a bit tricky question that we have to keep it in our mind. Yes, liver glycogen indirectly can give you ATP. How? Because liver glycogen inside the liver will break down till glucose. That glucose will be given out to the RBC. Inside RBC, it will go for production of 2 ATP. Right? Because all of you know, although glucose is given till the brain, but brain cells during starvation are actually predominantly surviving on ketone body breakdown than the glucose. I told you, in case of brain, if you ask him choice, what do you want to eat in a well-fed state, brain will raise hand, please give me glucose, I am so happy. But the same brain in fasting or prolonged fasting, that is starvation, will switch over to survive on ketone bodies. That's the reason here, though liver glycogen can be a source of ATP only in the RBC, but all of you know RBC's net gain of ATP is only 2 ATP, which is very negligible amount. That's the reason we are not picking up this answer, and the answer of this question would be option number B, liver glycogen, least likely to maintain ATP's demand. Very important, beta. The future depends on what we do today. We have to put our effort today. Many things will come and go. Many people will be there in your life to pull you down, and many people will be there to push you up. Forget about those people who are pulling you down. Try to respect the people who are always pushing you up. Ultimately, impossible word itself says, I am possible, my dear friends. You will be definitely able to achieve your goal in the upcoming FMG exam itself. Some questions integrated between pharma and biochem. Answer to this question, beta. Paresh, thank you so much for the right answer, beta. Yes, it is a bit tough question, but if you apply your common sense, you will be able to achieve the answer. Yes, the higher the option is answers, the answer is C. Please remember cardiac cells. ना यहाँ पर बेटा हम लोग देखेंगे, देखो cardiac cells. Please remember the cardiac muscle cells utilize, those of you who are thinking in the ALA, if you are thinking A, just remember RBCs utilize the lactate as fuel. RBCs, how can they utilize the lactate as fuel? Indirectly, beta. Lactate has to go from the RBCs to the liver. Liver will give you gluconeogenesis back to the glucose. Then glucose will be again given back to this. For that, that Cori cycle will be required. See here, first of all, step by step, we have to go for this. That who handles the lactate? I mean, basically, the question is asked in a way that Cori cycle is required maximum for which one? Cori cycle is done by maximum for which one? All of you know our heart muscles, it is always contracting, and heart muscles, my dear friends, all of you know, is one type of thing that never gets fatigued. There is no muscle cramp in the cardiac muscle. There is a muscle cramp in our skeletal muscles, but not in the cardiac muscle, because cardiac muscle, they can utilize the lactate as fuel because they are always pushing them. Yes, technically the option number A is also a bit correct over here, but if you ask me the option between A and C, definitely beta C will be a better answer than A for this particular question, because the amount of lactate that is generated in the RBCs and in the cardiac muscle, obviously in the cardiac muscle will be more, but they are able to handle them by completely metabolizing them. Okay, let us try to connect the dots. आज थोड़ा बाउंसर्स है, नथिंग टू पैनिक. फर्स्ट phase of the MCQs are bouncer, next phases of the MCQs will be easier to boost you up. आराम से चीजों को सीख लेते हैं ताकि एग्जाम में बाउंसर आए तो हैंडल कर पाए. ओके, आराम से. मेटफॉर्मिन, फर्स्ट ऑफ ऑल आई एम आस्किंग यू सिंपल क्वेश्चन, प्लीज टेल मी व्हाई द हेल मेटफॉर्मिन इनटेक विल प्रोड्यूस लैक्टिक एसिडोसिस. सबसे पहले ये चीज समझते हैं आराम से. मेटफॉर्मिन देने से पेशेंट में लैक्टिक एसिडोसिस क्यों होगा? आस्किंग यू ए वेरी सिंपल क्वेश्चन. व्हाट इज द लिंक? Why metformin leads to lactic acidosis? What does metformin do? Biguanides, alkyl biguanides, glucose uptake. Please remember this basically channelize more glucose uptake by the peripheral tissue, and if more glucose is delivered toward the peripheral tissue level, more glycolysis means more pyruvate means more lactate. Apart from that, please remember we had also discussed in our classes when we have talked about electron transport chain, आपको याद होगा complex 1 inhibitors, alka cheers rotenpiersin bar. Alka, one of the example we have talked about is alkyl biguanide, that is metformin. Metformin indirectly can inhibit complex number 1, which is the entry point of NADH plus H plus in the mitochondria. And if metformin is given in high doses, NADH plus H plus will not be able to enter through the complex number 1, due to which there will be build up of NADH plus H plus in the mitochondria, and it will backflow into cytosol, where it will catch hold of pyruvate, which is actually coming from the glucose breakdown, and that pyruvate will be easily tackled by lactate. Metformin dual damage. It is helping in glucose uptake, starting glycolysis, making pyruvate. From the other hand, it is NADH plus H plus which is returning to cytoplasm, and it is converted from pyruvate to lactate. That's the reason metformin देने से one of the common potential side effect is lactic acidosis, but it usually does not happen much because one of the savior is our cardiac muscle, to some extent also the RBCs, but RBCs are always busy with their own lactate. Cardiac muscles is the one that we have to remember as a best possible answer. I've given you some explanation better, just quickly brushing you through the main important point. Metformin can increase glucose uptake by the tissue that we have discussed, that lead to increased lactate formation. It can also block the complex number 1 of the electron transport chain. Metformin through an unknown mechanism appears to block lactate uptake by the liver. This could occur because of the reduced gluconeogenesis occurring in the liver in the presence of metformin, and lactate is the key substrate for the gluconeogenesis as well. Please remember, the cardiac muscle, please try to understand, the cardiac muscles with their massive amount of mitochondria will utilize lactate as fuel and can overcome the lactate buildup with the therapeutic doses of metformin. Cardiac muscle may please that massive mitochondria amount that we have, that can also temporarily store the lactate, and that can further be used up by the gluconeogenesis when it is going through the Cori cycle. But the temporary storage house for this lactate is actually cardiac muscle or heart. Yes, we did not discuss this during our classes, something extra over here. Please try to make a note of this. Usually 1 in 10,000 patients can lead to lactic acidosis, but usually cardiac muscles can handle that. Please remember, lactate does not enter the TCA cycle to be oxidized, as it first has to be converted to pyruvate, then to the acetyl CoA before it can enter to the TCA cycle. RBCs generate lactate but do not utilize it as a fuel because lactate is again converted to glucose. Glucose is utilized as a fuel further, and the kidney cells and the other cells do not utilize lactate to an appreciable extent as fuel as compared to the heart muscles. So heart muscles can directly utilize the lactate as their fuel because the amount of mitochondria over there is actually more. Please remember this. Now, easy question. People were telling आज बहुत सारे बाउंसर्स हो रहे हैं. नो मोर बाउंसर्स, प्रॉमिस. नो मोर बाउंसर्स. बाउंसर्स डाल दिए हैं. पावर प्ले इज डन. नाउ आराम से बैटिंग कीजिए और आंसर्स बोलिए. जस्ट टू बूस्ट यू अप बेटा. शलभ कहाँ गए? आज आंसर, ये आंसर सही होगा. थोड़ा सोच के आंसर करना है. व्हाट इज दिस केस? Right answer. Right answer. Right answer. Shalav, thank you so much. Right answer. Right answer. All of you are right answer. Yes, yes, ये हुआ ना बात. Right answer. Yes, this is a case of what? Basically Goa, but इसमें से O है. Please try to understand. This O is there. Nystagmus, ophthalmoplegia. Ataxia is there. Difficulty with the balance and when walking. See, loss of feeling in his hands and feet, this is basically leading to tingling sensation. बेटा ये जो वर्ड यहां पर चीज है, this is the thing that we can relate to tingling. This is the tingling sensation beta, right? So exactly not global confusion. Here they have not given the ideal triad, but looking at the nystagmus and the ataxia part, we can relate to this as a B1 deficiency. And आपको याद होगा, we had talked about B1 deficiency that is mainly seen in a patient of beriberi. So here if you ask me, the diagnosis of this particular MCQ is actually beriberi. What type of beriberi? It is actually a type of dry beriberi, not wet beriberi beta, because here they have not talked about any type of cardiac involvement or edema. So it is not a case of wet beriberi. It is a plain and simple case of dry beriberi. And in patients of dry beriberi, we actually see tingling sensation, nystagmus, and also ataxic type of gait. Global confusion is not much seen over here because global confusion part is mainly associated with Wernicke's encephalopathy, which is mainly due to CNS involvement. But here it is mainly restricted to only PNS, that is peripheral nervous system, due to which the patient is only presenting to us with tingling sensation, paresthesia, pins and needles. ये सब हो रहा है. Global confusion यहाँ पर नहीं है. No global confusion over here. Try to make a note of this. वो था Wernicke-Korsakoff syndrome में with Wernicke's encephalopathy plus the features of confabulation. That was a bit different. But here it is a case of dry beriberi. And in beriberi, due to B1 deficiency, all of us know these three guys, B, C, D and D, they are not dependent on vitamin B1. Vitamin B1 is one of the part and parcel of alpha ketoglutarate dehydrogenase complex enzyme because it is the guy that is for our ODC, oxidative decarboxylation. Oxidative decarboxylation B1, B2, B3 as well as B5. If you ask me what about the other things which are required, other coenzyme for succinate dehydrogenase, इसको भी लिख देते हैं. For SDH succinate dehydrogenase, it is FAD or vitamin B2. Malate dehydrogenase, it is NAD or vitamin B3. Pyruvate carboxylase, it is biotin B7. These are the other coenzymes for these three enzymes. Please try to understand. This is an enzyme for gluconeogenesis. These two enzymes are for Krebs cycle, including the third one over here, alpha ketoglutarate dehydrogenase complex. Oxidative decarboxylation reaction. ये beriberi का question है. Please try to make a note of this. I hope all of you remember tingling sensation. What was the order? Related to vitamin B12, more than B1, then B6 excess, then B6 deficiency, then to some extent B9 deficiency can also be thought of. Then the B9, B12, B1. Second most common cause from the vitamin list is due to beriberi, mainly the dry beriberi, that we have to keep a note of this. This is a question of dry beriberi over here, dry beriberi. Okay. Given you the explanation of this, please try to make a note of this whenever you are free. Please try to have a, I have already made you FAD, NAD, biotin. These things are there. These are the 5 coenzymes which are required for this. One of the non-vitamin coenzyme was lipoic acid. कहाँ गया? यहाँ पर है. Lipoic acid is one of the non-vitamin type of coenzyme. चलो बाउंसर नहीं मारेंगे, इजी क्वेश्चन है अभी सब. All of you know Lish-Nihan syndrome. Lish-Nihan syndrome, mutilating the fingers. Please remember HGPRTS, hypoxanthine guanine phosphoribosyl transferase. प्लीज रिमेंबर, खुद ही ने खुद का लिया वाला क्वेश्चन है ये. प्लीज ट्राई टू रिमेंबर, इंपॉर्टेंट पॉइंट बेटा. This is classical presentation of the Lish-Nihan syndrome. Adenosine deaminase deficiency, ADA, if it is deficient, we have severe combined immunodeficiency. ADA deficiency leads to SCID, severe combined immunodeficiency is beta SCID. Acid maltase deficiency lead to Pompey's disease. APRTS deficiency lead to APRTS deficiency disorder itself. It doesn't have any specific name. All of us know in the Lish-Nihan syndrome, one of the major challenge is this: babies are actually having uncontrollable urge to destroy their own body part. They try to mutilate their fingers. Sometimes they try to bite off their lower lip. Most of the time, as you can see over here, unfortunate, the lower lips are quite damaged. The mutilation of the finger, as you can see in this case, the nail beds are totally exposed. The complete mutilation has been done. Sometimes they also try to give oral plug over here so that they not able to bite their lower lip. And sometimes the part of the tongue or the lower lip can be also bitten off. In case of young patients, sometimes they are put in a chair and their hands and feet are actually totally tied off, so that they don't allow themselves to destroy their own body parts. Very pathetic type of disorder, Lish-Nihan syndrome. Usually these children do not survive for long. All of you know the mnemonic for this is that self-confident men get heavy success. Self-confident men get heavy success. From the word self, there is self mutilation. That is one of the hallmark thing that is over here. Confidence, we have got choreoathetosis. What is choreoathetosis? That is the involuntary jerky movements. Choreoathetosis. D से हम लोग याद करेंगे डिस्टोनिया. MEN से मेंटल रिटार्डेशन हो सकता है. साथ में एक्सट्रीमली हॉस्टाइल मेल चाइल्ड. एंड एन से हम लोग याद करेंगे nephrolithiasis, which is also shown in this particular question as a low urine output. गेट से हम लोग याद करेंगे गाउट. but sometime it might not lead to gout, but there is only presence of hyperuricemia, and the child over here is spastic child, that is spasticity. These are the points that we have to remember over here, Betaji. Spasticity. Please remember self mutilation, chorioacidosis dystonia, mental retardation, male child. M4 also people say male, but this is extremely hostile male child. Gout, hyperuricemia, and success say spasticity. These are the points that we have to remember. Leishman syndrome. We also have another milder variety of this disorder, which is called as Keeley-Sigmiller syndrome, which is there is a partial deficiency of the HGPRTS. Complete deficiency of HGPRTS, Leishman syndrome. Partial deficiency of HGPRTS, Keeley-Sigmiller syndrome. Remember, in Keeley-Sigmiller syndrome, what happens? The cell mutilation part is actually not seen much. Rather, the chorioacidosis part is actually more in case of the partial deficiency, that is Keeley-Sigmiller syndrome. Please try to remember this. Diagnosis is already written. This is again, we did not discuss this during our regular classes. Some portions of molecular biology I told you will be discussed during the 25 most important, and this is one of the topic known as DNA repair defects disorders due to DNA repair defect. Yes, all of you are writing the right answer. Yes, direct question beta. It has been also asked exactly like this in our FMG exam. It is NER, nucleotide excision repair. This is actually one of the most common type of DNA repairs. Nucleotide excision repair, my dear friend, is one of the most common type of DNA repair. See, DNA can be damaged due to various reasons. Various reasons are there, but there are more or less 6 different types of repairs are there which can save our human DNA, which can prevent us from having some disorders. Nuclear excision repair defect, NER, which is the most common type, and if this is not working to its full potential, then the child, or the particularly in older age patients also, sometime in young onset, we can get to see a disorder called as xeroderma pigmentosum, which is actually a precancerous. XP is a type of precancerous type of thing that can lead to skin cancer later on. These are the features. Let us quickly discuss this topic of DNA repair mechanisms and their defect. Total 6 types are there. At least try to highlight the names and whose damage can lead to what type of disorders. There is one something called as exonucleolytic proofreading, which is not discussed much in UG level. Let us try to understand from the second most important one, NER. We have two disorders mainly. One is XP and the second is trichothiodystrophy, TTD. Then the second one we have is strand directed mismatch repair. इसको लोग MMR बोलते हैं. Not the measles, mumps, rubella. This is the mismatch repair. And if there is a defect of mismatch repair, if MMR is not performing at our molecular level, then we have a disorder called as Lynch syndrome. Lynch syndrome. What is Lynch syndrome? It is HNPCC, hereditary non-polyposis colon cancer or colorectal cancer. Overlapping with surgery topic, HNPCC is due to the defect of mismatch repair. We have a defect of base excision repair, जिसमें आते हैं मैप. What is मैप? मुति एसोसिएटेड पॉलीपोसिस, MUTYH, लोग इसको मुति बोलते हैं, मुति एसोसिएटेड पॉलीएसिस. Please remember, don't pronounce it in a different way, then the meaning will change. Okay. Then we have DSBs. What is DSB stands for? DSB stands for double stranded break repairs. Double strand break repairs. And this is of two types. One is HR, not human resources, homologous recombination. And another one is NHEJ, non-homologous end joining. If it is due to the defect of homologous recombination, we have one of the very frequently asked question, Bloom syndrome. हम लोग बात करेंगे because Bloom syndrome and xeroderma pigmentosum are little bit overlapping features they share. Werner syndrome, Rothmund-Thimson syndrome, BRCA1, BRCA2, and Neurobechet's disease, Neurobechet syndrome. All these are there. At least remember Bloom syndrome. NHEJ, non-homologous. Please remember N joining. Ionizing radiation, hypersensitivity, loss of lymphocytes, ataxia telangiectasia. This is important. Ataxia telangiectasia mutated. ATM gene, what is called as ataxia telangiectasia mutated gene. जीन का नाम ही है ATM gene. Please remember. Ataxia telangiectasia mutated gene. जीन का नाम ही ऐसा है ATM gene, due to which we have a disorder called as ataxia telangiectasia. And please remember, there is something called as transcription coupled NER, due to which we have something called as Collagen syndrome. Collagen syndrome. Please remember, I am putting star mark on these four: xeroderma pigmentosum, HNPCC, Bloom syndrome, and please remember Collagen syndrome, because this four has been asked. If possible, please put another star mark on ataxia telangiectasia mutated or ATM. These five that you should know for your upcoming FMGE exam, that which disorder is due to which type of DNA repair defect. Which type of DNA repair defect. Some quick words between Bloom syndrome versus xeroderma pigmentosum. Please remember, in Bloom syndrome, we have something called as phototoxicity. Phototoxicity, important word, beta. Please try to choose this word, phototoxicity. But please remember, in case of xeroderma pigmentosum, this is not only restricted to phototoxicity, but it can lead to photocarcinogenicity. Photocarcinogenicity, because here I just now told you in the MCQ, in XP, important point to be noted, skin cancers, they are the predisposing ones. So here I will write big and bold. Please remember, photocarcinogenicity. उसमें है सिर्फ और सिर्फ फोटोटॉक्सिसिटी. इन केस ऑफ ब्लूम खिला phototoxicity, but यहाँ पर XP photocarcinogenicity. Blistering sunburns are there, dry xerost type of dry thin type of skin will be there, and freckling, multiple cracks will be appearing before the age of 2, which is also called as lentigos. Please remember, and patches of increased and decreased skin pigmentation, which is called as poikiloderma. Poikiloderma is a common feature. Poikiloderma is a common feature that might be also possible in case of bloom. Eye sensitivity to bright light, photophobia is there in case of xeroderma pigmentosum. Eye surface cancers, skin aging, skin cancers are there, but the important word over here is photocarcinogenicity. Bloom में क्या होता है? No photocarcinogenicity that is seen in xeroderma pigmentosum. Small clusters of enlarged blood vessels may appear in the rash in the eyes. Some clusters or clump of blood vessels, people call it as a clump, CLUMP, clump of blood vessels in the rashes. Other signs, please remember, patches of skin that may be lighter or darker, which is also called as poikiloderma. Common feature, poikiloderma. Please remember, poikiloderma. Increased and decreased skin pigmentation. कहीं कहीं ज़्यादा patches, ज़्यादा darker skin, कहीं कहीं पर ज़्यादा lighter skin. Please remember, lighter darker shades of skin, different shades. Please remember, known as poikiloderma. Small jaw, large ears. Recently we have asked a question with this high pitched voice. Please make a note. I will put a star mark over here. High pitched voice, ये वाला MCQ में यूज किया गया था in your FMGE exam. High pitched voice. Fertility problems, learning problems, these things are there. There is not much of cancer chances, but increased risk of developing cancer at an early age, mainly lymphoma, leukemia, and GIT cancers. But here, this is the important one: skin, photocarcinogenicity. Skin cancers are never ever seen in case of Bloom syndrome, but it is quite possible in case of xeroderma pigmentosum. poikiloderma will be a common word given to confuse you. You should see whether it is just restricted to phototoxicity or whether it is going for photocarcinogenicity. One of the extra hint that they had given was high pitched voice, hoarseness of the voice, होर्सनेस, कम उम्र का लड़का आपके पास आया, बड़े एज के जैसा साउंड कर रहा है, वेरी भारी भारी शब्द दे रहा है. प्लीज रिमेंबर हाई पिच्ड वॉइस, इंपॉर्टेंट. ओके, इजी क्वेश्चंस. Right answer. Right answer. Right answer. Right answer, my dear friends. This answer of this question is 5-hydroxyindole acetic acid. Yes. Question number C is the right answer, my dear friends. Yes. 5-hydroxyindole acetic acid. What is this case? This is, my dear friends, revealed to be a case of malignant argentophenoma. इसको कभी कभार लोग हम लोग बोलते हैं MCS, that is malignant carcinoid syndrome, MCS, or please remember we also call it as a malignant carcinoid syndrome or MCS, malignant carcinoid syndrome. Now what is it? Let us try to understand quickly. With a 12-year-old boy, pediatric OPD, recurrent cramping, abdominal pain. Okay, positive findings. 10 to 15 minutes confined primarily to the lower abdomen after meals. Please remember, X-ray showed narrowing of the mid jejunum and on explorative laparotomy the further mesenteric biopsy revealed to case of argentophenoma. Mainly बहुत लंबा चौड़ा कहानी है. All the story boils down to only one single fact, that it is a case of MCS, malignant carcinoid syndrome. Small bowel resection was done to save that boy. And which of the following urinary marker is most likely used in the monitoring prognosis during the post-operative period? Please remember, in malignant carcinoid syndrome, I basically told you, basically the 5-HIAA will be more than 500. Please remember. Please remember, more than 500 milligram per DL it can be there in the urine. Basically हम लोगों को याद करना पड़ेगा, it is the more than 500 value over unit. Also if you don't remember, that is also still okay. Mainly it should be less than 5, but in case of malignant carcinoid syndrome, this is the marker that is going to be high. And I told you this is the gold standard also for this. This is the gold standard marker for the malignant carcinoid syndrome. In these cases, we basically have 60% of the tryptophan channelized towards the production of serotonin. High serotonin is broken down by an enzyme called as MAO, and MAO gives you the product 5-hydroxyindole acetic acid. And please remember, here the people, mainly patients with episodic diarrhea, intermittent diarrhea. There is also hot flush, excessive sweating, pellagra like symptoms also quite be possible, although those features have not been given over here. But in this question, the diagnosis itself is told to all of us, that is the malignant argentophenoma, and the diagnostic pattern is done by this FIGLU, which is one of the old marker for benign deficiency. 3-hydroxyanthelinic acid is not a marker of anything. 3,4-dihydroxyphenylalanine is nothing but the other name of DOPA, DOPA, dihydroxylated phenylalanine, that is nothing but the other name of DOPA. Quick things from this, the pathways we have discussed during the classes, that serotonin basically is broken down by the help of enzyme MAO to this guy 5-hydroxyindole acetic acid, and this is the guy that basically comes out in the urine as one of the urinary marker of malignant carcinoid syndrome. I told you, even if 5-HIAA is increased is a better test. Serum serotonin also will be high, but 5-HIAA is a better marker. Neuroendocrine markers, we have heard about CGA, NSE and synaptophysin. I told you verbally during the classes but did not write it in our notes. Clinical symptoms: intermittent diarrhea, flushing, sweating, fluctuating hypertension, and pellagra like symptoms are also there. These things might be also added as an extra additional point for malignant carcinoid syndrome. Please try to remember this. My dear friends, it is you who has to get the job done. Nobody else will be able to help you out on the exam day. And my sincere request to all of you is that whenever you are sitting in front of the computer screen and choosing the answers, clicking the option with your mouse, please do not change the answers. Whenever you are attempting any question, and what is the first gut feeling that brings up in your mind, and you choose for one answer, and by looking at someone else's screen you change the answer and you lose 1 mark, those things should never ever happen. You have studied, you have gone through the workbooks, you have given the mock tests, you have known the topic, you know better than anyone on that exam hall room. So trust your knowledge, trust your notes, trust your gut feeling, and never ever change the answer. Whatever pops up in your mind in the first go, please stick to that. Avoid silly mistakes. Read the question carefully. Read the last line first of the long questions, clinical type questions. Look for positive findings. Arrive at your diagnosis. That is the way we have to approach better, and definitely you will be having enough time. In some MCQs you will be able to save time. It might not take 1 minute, it might be done in 10 seconds, 15 seconds, 20 seconds, 25 seconds. You are having some extra additional seconds that can be utilized in some long 1 or 2 kilometer long MCQs, where actually reading the question gives you the answer. That is the way forward better. It is never one MCQ 1 minute. No, it is not like that. Some MCQs 10 seconds, some MCQs 2 minutes. Read the question, then arrive at your diagnosis. That is the way forward, and wishing you all the very best that you can apply your hard-earned knowledge in the last 5 years and you can imply that on solving the MCQs correctly on the exam day. 16th question, easy question. गोवा जाएंगे एग्जाम के बाद, पहले पढ़ लेते हैं थोड़ा. What is this diagnosis? Thank you so much. And all of you are right with the diagnosis of McArdle's disease. Please remember, McArdle disease. See, in this question, let us try to learn something new. Let us try to learn. Don't just mug it up. I know this image has been helpful, which is showing you the myoglobinuria, cola colored urine, cherry soda pop, all those things which are there. Cherry soda pop, yes, it is one of the positive findings. Seal the deal. Cherry soda pop देखते ही McArdle disease mark करना है. मैंने सिखाया. Okay, you have done it. But let us try to read the question carefully. Let us learn something new. 19-year-old, health clinic, exercise program, want to lose 6 to 8 kg. First day of weightlifting. Her, female gender. Oh. No offense, please. Female gender is more predominant over here with these attacks. Her first day of weightlifting, She became extremely sore during the first few minutes workout but could continue exercise easily after 10 minutes. My dear friends, I have just now told you in another MCQ that how can we prolong the exercise for longer time. Different type of muscle memory, different type of ATP production by sprinters and marathon runners. Here the hint is, after 10 minutes she is able to perform her exercise, but for the first 10 minutes there is a difficulty. First 1 minute creatine phosphate, okay. Next few minutes muscle glycogenolysis problem, because McArdle disease, M for M, it is the deficiency of muscle glycogen phosphorylase. And if muscle glycogen is not broken down due to the deficiency of the rate limiting enzyme of glycogenolysis pathway in the muscle, then muscle glycogen is not going to give us those 8 ATP during heavy exercise. So now you look at the second option available as a backup other than muscle glycogen, known as myoglobin. And when myoglobin is hammered hard by those heavy weight that you are lifting, this myoglobin breakdown will release ATP, and to some extent myoglobin as it is will be coming out in blood circulation from the muscle as it is liberated, and it is finally passed in the urine, giving us the classical cola colored urine, cherry soda pop myoglobinuria. Now please try to understand, this myoglobin also, there is a limit till which it can break down. Once myoglobin is also getting exhausted out, myoglobinuria is setting in, then what happens? Then that switch over happens from those muscle protein. We had talked about that alanine comes to the liver, pyruvate to glucose, glucose goes back to the skeletal muscle, muscle starts with again glycolysis, that Cahill cycle part which we were discussing in our today's session. I told you during that glycolysis, when it restarts in the muscle, when alanine goes to the pyruvate to glucose, glucose to pyruvate again, when this glycolysis restarts in the skeletal muscle, again there will be a second surge, second power, second wind phenomenon in case of patients of the McArdle's disease. 10 minute के बाद things become easy. First 1 minute okay, next few minutes is very difficult to do the exercise. लग रहा है कि exercise नहीं हो पाएगा, छोड़ देते हैं, नहीं कर पाएंगे, छोड़ देंगे, impossible. But after 10 minutes she gets some energy from somewhere with which she is able to continue her exercise, and this sort of with ease that the patients are able to perform exercise beyond 10 minutes, this is called as second wind phenomenon. इसी का ही नाम होता है बेटा second wind phenomenon, and this is due to that mechanism which we had discussed earlier in our today's session, when muscle proteins start breaking down after myoglobin. Myoglobin is not the only muscle protein, right? We have also many muscle amino acids that can break down to give ammonia. Ammonia is carried by alanine, pyruvate glucose, glucose back to the muscle to go for glycolysis back to pyruvate, and whenever that glycolysis is taking place in the muscle, it is generating ATP. That will give you the second surge, second time power. कहीं से अचानक पावर मिल गया 10 मिनट के बाद. First 1 minute okay, 9 minutes difficult, 10 minutes onward things normalize. This is called as second wind phenomenon, and this is actually one of the hallmark of also McArdle's disease. Please remember. Point to be noted, this patient also shows elevated level of creatine kinase, because I told you in absence of the second backup, the first backup, that is creatine phosphate, has to work for little more time, maybe instead of 1 minute, 1.5 minutes or 2 minutes. So creatine kinase CK3 in the skeletal muscle will overpower, and there will be rise of the CK3 in the blood as well. Negative for blood but positive for myoglobin. No hematuria, but that is myoglobinuria. What about Tarui disease? Remember, Tarui disease is also confusing a bit because Tarui disease also presents with exercise intolerance, just like मैकार्डल डिजीज. ओके, टारुई डिजीज एंड मैकार्डल डिजीज दोनों में ही एक चीज कॉमन है, दैट इज नोन एज एक्सरसाइज इंटॉलरेंस. जिम में जाने के बाद जिम करने में दिक्कत. बट इन मैकार्डल डिजीज द जिम कैन बी परफॉर्म्ड for longer time due to second wind, second surge, second power after 10 minutes. But in case of Tarui disease, second wind phenomenon is never seen. Please remember, McArdle's disease versus Tarui's disease. Second wind phenomenon, it is positive over here, negative over here. Second wind phenomenon. Please remember, if you give high carbohydrate diet during the gym, high carbohydrate diet, कुछ carbs, banana, glucon D, carbohydrate sources, if you are giving to the patients of the McArdle's disease, then things will improve over here. Because I told you the source of ATP beyond 10 minutes, it is going to be the glycolysis in the muscle. As you are giving glucose from outside, glucose will be reaching the muscle and muscle will perform glycolysis to give you ATP. So things will improve. I am asking, in Tarui's disease, what will happen if we give high carbohydrate diet to this patient of Tarui disease? What will happen in case of Tarui disease? Tarui disease में जिम के दौरान exercise intolerance is there. Exercise intolerance, it is positive over here, दोनों में ही positive होगा. Exercise intolerance is the common feature between McArdle and Tarui. Second wind phenomenon only in case of McArdle disease, not in case of Tarui disease. But I am asking, what will happen if we give high carb diet? हाई कार्ब डाइट देने से किस में क्या होगा? इंप्रूव होगा किस में? मैकार्डल डिजीज में. एंड व्हाट विल बी द इफेक्ट ऑन टारुइज डिजीज? प्लीज रिमेंबर, इन केस ऑफ टारुइज डिजीज it will worsen the symptoms, because Tarui disease, it is actually due to the deficiency of the PFK1 deficiency, that is the rate limiting enzyme of the glycolysis. And if you feed more glucose from outside which cannot be metabolized by the muscle, again glycogenesis will be triggered in the skeletal muscle, which will worsen the problem. Please remember, high carbohydrate diet is actually one of the solutions that can be prescribed to the patient suffering from McArdle disease if they want to do gym for longer time. But similarly, this my dear friends, Tarui disease में ये चीज worsen होगा, क्योंकि whenever we give glucose, it has to go for glycolysis. But in Tarui disease, PFK1, that is the rate limiting enzyme of glycolysis, it is actually deficient, so they cannot utilize the carbohydrate in the muscle to generate ATP. Rather, it will be going for more deposition of the muscle glycogen. Please remember this. Okay, some points regarding McArdle and Tarui. This question answer beta. The correct answer is B, that is multiple myeloma. But I will try to explain Why not it is the option number A, that is MGUS, that is monoclonal gammopathy of undetermined signaling. Let us try to learn this. Yes, in our notes, in our classes, we had discussed about this M band, M spike, all those things. I don't want to waste time on this. And we have also talked about one of the classical finding of patients suffering from multiple myeloma, that they are going to present with something called as CRAP. What is CRAP? Hypercalcemia, आर से रेनल स्टोन्स. रेनल स्टोन्स कहाँ है? पेनफुल यूरिनेशन. पेनफुल यूरिनेशन मीन्स रेनल स्टोन्स. ओके. ए से एनीमिया. एनीमिया नॉर्मोसाइटिक नॉर्मोक्रोमिक एनीमिया. एंड बी से बोन पेन, लो बैक पेन. लो बैक पेन. एवरीथिंग इज मैचिंग. क्लासिकल फीचर ऑफ क्रैब इज मेंशन्ड ओवर हियर. पूरा क्रैब यहां पर है. क्रैब इज देयर. ओके. क्रैब इज देयर. Bradshaw test come positive, but Jacobson heat test come negative. Serum protein electrophoresis was there because SPE, we had discussed serum protein electrophoresis, my dear friends, we have discussed, is the gold standard for diagnosis of multiple myeloma, and it has been showing this thing in densitometry. You are able to see the gamma, that is the M spike over here, that is M spike over here, M band on the glass slide, M spike on densitometry finding on a computer screen. So it is a case of multiple myeloma. But what about this MGUS, monoclonal gammopathy of undetermined signaling? Let us learn something new in our today's session. Okay. First of all, this electrophoresis glass light pattern. For everyone over here, beta, we all know during the electrophoresis there is a movement of the proteins present in the serum in the direction of negative to positive. Negative to positive. Please remember, this fraction is called as gamma. Beta can be sometimes divided into two parts, beta 1, beta 2, then alpha 2, alpha 1, then this band is called as albumin. Then this band is called as albumin, which is closest to the anode. Anode is the positive electrode, negative is the cathode, that is the negative electrode. Please remember that is the normal pattern, that they are monally divided in a case of agar gel electrophoresis into 5 or 6 different bands. Sometimes beta 2 and beta 1 can be clustered together in a single band like this. ये अलग अलग ना होकर दोनों एक साथ cluster हो सकते हैं, beta 2 and beta 1 together. In multiple myeloma, what happens? Basically, we get an extra additional band. This is the extra additional band that we are seeing between the gamma and the beta zones, which is called as monoclonal band or the M band. Now, sometimes in chronic infection cases, what can happen, beta? Chronic infection, as immunoglobulins has to rise because the antibodies has to fight. That's why there is increased in the case of gamma region over here, increased, and alpha 1 alpha 2 to some extent can also increase over here. In case of nephrotic syndrome, please remember, in nephrotic syndrome, first of all, you are seeing that the band of albumin is very pale. Other areas were actually darker blue in shade, but in case of over here, the albumin concentration is becoming very low because the child is suffering from nephrotic syndrome. But one of the important point to be noted, look at this band alpha 2. Alpha 2 becomes wider in case of nephrotic syndrome. Two things that we have to appreciate in the electrophoresis pattern. What are the two things? Alpha 2 wider and albumin will be slightly lower. Just a moment, beta. Okay, so yeah, sorry for this. There was some important call beta. So in nephrotic syndrome, what happens? Albumin, as it is lost in the urine, the albumin band will be also almost negligible over here. As we can see, basically in this image, what we have to remember, this albumin band, which has to be darker blue like this albumin, my dear friends, is going to be very pale type of band, or this band might be totally non existent over here. ये एल्बुमिन वाला बैंड दिखेगा भी नहीं, ऐसा भी हो सकता है. It might not be present, but the alpha 2 band will be little bit wider. That is the prominent alpha 2 band in case of our nephrotic syndrome. So hypoalbuminemia and prominent alpha 2 band. These three things has been asked as a question in our exam. Please remember, in case of infection, in case of nephrotic syndrome, as well as in case of multiple myeloma. Now, some of you had some doubt because I saw some answers that you had also talked about this MGUS. Now, please remember, multiple myeloma and the precursors of the plasma disorders. All of us know, in case of this multiple myeloma also, this is a plasmacytoma, and ultimately what happens, the plasma cells hyperplasia is also seen, and it is the B type of cells, B cells, that is undergoing some cancerous changes, due to which there is a mismatch or overproduction between the heavy chains and the light chains, and the light chains are actually quite more, where kappa and lambda are over produced, and ultimately they are lost in the urine, which is called as Baines-Jones proteinuria, जिसको हम लोग बोलते हैं BJPs are coming out in urine. Now, important point to be noted, beta G, that there is also some another disorder called as MGUS. What is MGUS? Monoclonal gammopathy of undetermined significance, where we actually see M spike. M spike is not only seen in case of multiple myeloma, it can be seen in case of MGUS, but here the peak will not be that high as compared to our normal electrophoretic pattern, that almost like the albumin. Look at this image, almost that, look at the peak of albumin and the peak of IgG, gamma globulin, is also matching almost with each other. This peak, sometime it might be only till over here. It might not be as elevated like the peak of albumin, it might be half or below half, but even that sometime also called as M spike. But in this case of M spike, please remember, the spike must be less than 3 gram per deciliter. Plasma cells, if you go for biopsy over here, please remember, plasma cells will be less than 10% of the bone marrow. It is not that much elevated like in case of multiple myeloma. And important, no crab. MGUS में क्रैब नहीं होता, एम स्पाइक होता है. प्लाज्मा सेल hyperplasia, plasma cell more in number is possible, but less than 10% of the bone marrow, but no crab. Please remember, MGUS can predispose gradually till multiple myeloma. As we can see, there is an arrow that is going from the top to bottom. It can predispose in this way. But in between, we have something called as SMM, that is called as smoldering, SMOLDERING, smoldering multiple myeloma, where the monoclonal spike is there, 3 gram per deciliter, and it is almost of same height like the M spike of multiple myeloma. Because in case of multiple myeloma also, the M spike is due to more than 3 gram per deciliter. It is also due to more than 3 gram per deciliter. But here, there is also no crab features. Same height, peak, but no crab. Plasma cell more than 10% of the bone marrow. It is called as smoldering multiple myeloma. And what is our topic? Multiple myeloma, more than 3 gram per deciliter, plasma cells achieve crab features. That's why in the last MCQ, I wrote that word big and bold, crab. ये होना ही पड़ेगा if it has to be a case of multiple myeloma. Crab features are actually not there in the MGUS and the smoldering type. Apart from this, plasma cells will be more than 60%. Very important biopsy that we can go for. What is SFLC? Serum free light chains beta. These are also elevated, or more than one focal lesions on the MRI. On the MRI, we can also go for lesion. अच्छा, what is the MRI finding is in case of multiple myeloma? ये MRI के बारे में बात हो रहा है, although it is not my topic, but still MRI में क्या देखते हैं हम लोग? एमआरआई में कुछ होता है वो पता नहीं। एमआरआई एमआरआई स्कैनिंग ऑफ एमआरआई में क्या दिखता है मल्टीपल माइलोमा में? इन मल्टीपल माइलोमा व्हाट डू यू गेट टू सी इन एमआरआई? देयर इज समथिंग कॉल्ड एज, please remember, on MRI scanning, please remember that is called as punched out lesions, punched out lesion, and also known as the raindrop type of skull. Please try to look at this image बेटा। ऐसा देख के लग रहा है कि आपने पानी का बूंद छिड़का दिया है हमारे स्कल के ऊपर। दिस इज द क्लासिकल अपीयरेंस ऑफ द मॉथ ईटन अपीयरेंस, रेन ड्रॉप स्कल भी इसको बोलते हैं। प्लीज ट्राई टू अंडरस्टैंड दिस इज बेटा, दिस इज द पंच्ड आउट lesions. These are the areas where the bone damage is there. It is not only going to damage our vertebral column, low back pain, it can also damage the skull. It is classically इसको बोलते हैं रेन ड्रॉप स्कल। बिल्कुल रेन ड्रॉप स्कल वाला अपीयरेंस होता है ये। प्लीज ट्राई टू मेक ए नोट ऑफ दिस। रेन ड्रॉप स्कल, पंच्ड आउट lesions इसको बोला जाता है। सो दिस इज द थिंग दैट वी हैव टू रिमेंबर, the predispositions from MGUS to smoldering to ultimately a case of multiple myeloma. Try to remember this. ओके, इजी क्वेश्चंस जल्दी से करते हैं। इजी क्वेश्चंस आफ्टर मल्टीपल माइलोमा। इजी क्वेश्चन, इमेज से डायग्नोसिस हो जाएगा, इमेज से डायग्नोसिस हो जाएगा। व्हाट इज दैट इमेज स्टैंड्स फॉर? हेलो माय डियर फ्रेंड्स, टेंजियस डिजीज, सही जवाब, राइट आंसर, थैंक यू सो मच, ग्रेट ग्रेट। टेंजियस डिजीज, टेंजियर डिजीज में हम लोगों ने बात किया था ऑरेंज येलो टॉन्सिल्स। यस, ऑल ऑफ यू आर राइट, थैंक यू सो मच बेटा। एंड टेंजियस डिजीज, बाय चांस इफ दे आस्क यू व्हाट इज द जीन म्यूटेशन, प्लीज रिमेंबर दिस इज एटीपी बाइंडिंग कैसेट। इसको लोग ABCA1 जीन म्यूटेशन भी बोलते हैं। एटीपी बाइंडिंग कैसेट ट्रांसपोर्टर प्रोटीन A1 म्यूटेशन। ए बीटा लाइपोप्रोटीनेमिया, it is sorry, it is due to MTTP gene mutation. What is MTTP? Microsomal triglyceride transfer protein, MTTP gene mutation. Noram disease, Noram disease is actually complete LCAT deficiency. Woolman disease, deficiency of lysosomal acid lipase or cholesterol ester hydrolase or sometime hormone sensitive lipase, or sometime hormone sensitive lipase. These are the four disorders which also comes under the topic of dyslipidemia beta. A beta lipoproteinemia where steatorrhea is seen. B number वाले जितने भी lipoproteins होते हैं all are deficient. Chylomicron, VLDL, IDL, LDL are actually deprived. Tangier disease, HDL is very low, due to which LDL will have a free hand and LDL will gradually increase, and this is the cholesterol deposition starts from the tonsils, which makes the tonsils orange yellow tonsils. That is the first sign of patients of Tangiers disease. Please remember, hypo alpha lipoproteinemia is the other name. Please try to understand. Serum HDL is also almost close to nil. Please remember. Question number 19. Partial LCAT deficiency is called as the fish eye disease. That is fish eye disease, partial LCAT deficiency. Norum disease is complete LCAT deficiency. Okay, question number 19. What is this case? It is a case of PKU, phenylketonuria. इम्पोर्टेंट हिंट, अरे नहीं, दोबारा पढ़ो रे। जो समझ में नहीं आएगा उसको डी मार्क कर देना है। क्या ये क्या है? व्हाट इज दैट? आई टोल्ड यू, इफ यू रियली डोंट नो द आंसर ऑफ सम क्वेश्चन देन ओनली वी कैन मार्क द आंसर एज डी। अरे बट यू नो दिस क्वेश्चन, रीड द क्वेश्चन, क्या है ये? व्हाट इज दिस क्वेश्चन? ओ रे बाबा रे, ओ माय गॉड। हेलो, look at this question, look at this question. It is a case of PKU, phenylketonuria. Phenylketonuria, okay. More than 20 is positive, so 35, it is a case of PKU, phenylketonuria ही है। Please remember, tyrosine deficiencies are also apparent, okay. Enzymatic analysis culture show normal activity of phenylalanine hydroxylase. We have talked about classical PKU and non-classical PKU. First of all, please tell me, is it a case of classical PKU or non-classical PKU? Is it a case of classical PKU or non-classical PKU? डायग्नोसिस क्या है यहाँ पर? क्लासिकल है कि नॉन क्लासिकल PKU है? My dear friends, please try to understand, as there is a normal activity of the phenylalanine hydroxylase, but still the patient is suffering from phenylketonuria, then here the diagnosis for us will be non-classical type of PKU. And in non-classical PKU, no, not classical beta, non-classical PKU, because in classical PKU, which is the enzyme that is deficient beta G, it is the phenylalanine hydroxylase enzyme which will be deficient. But here it is normal. This is the important word over here. Here it is normal activity of phenylalanine hydroxylase. That's the reason it is not a case of classical. Non-classical PKU, that is mainly seen, prone seen in to be in adult, and this is the problem with the defect of coenzyme. And what is the coenzyme we have discussed? That is biopterin. What is the active form of biopterin? Tetrahydrobiopterin. So the right answer of this question will be biopterin is a deficiency of function in which of the following coenzyme? ये coenzyme से question है बेटा, read the last line first, that it is going to be biopterin, because biopterin is the important coenzyme for phenylalanine to tyrosine conversion. Let us do a quick recap of this question beta ji. All of us know phenylalanine has to be converted to what? Tyrosine. In between we have the enzyme called as phenylalanine hydroxylase, right? But once this is given to that, then we have studied that tetrahydrobiopterin will be converted to what? Dihydrobiopterin. And once DHB is again reconverted back to THB, there is an enzyme called as dihydrobiopterin reductase, and if this second enzyme is deficient, then we have non-classical. If this main enzyme is deficient, then we have got classical type of phenylketonuria, right? So please make a note of this. In this case, as the MCQ says, this enzyme is normal, it must be due to the defect of dihydrobiopterin reductase, which is associated with which type of coenzyme? Biopterin. Biopterin is the answer over here of this question. Please make a note of this. Answer to this question beta. सही जवाब, सही जवाब, सही जवाब, बिल्कुल राइट आंसर. थैंक यू सो मच फॉर गिविंग मी द. This is the main hint. What is the main hint over here? Urine for methyl malonyl CoA was also elevated, and they have asked about the vitamin deficiency. What is this case? This is a case of homocystinuria. Homocystinuria. Please remember, this is quite evident over here because the serum homocysteine concentration is quite high, marginally high, not very high. That's why it is not a case of classical homocystinuria beta. Again, it is a type of non-classical type of homocystinuria. Non-classical type of homocystinuria that we are discussing here. It is not due to any vitamin, sorry, not due to any direct enzyme deficiency beta. It is related to some vitamin. It can be B6, it can be B9, or it can be B12. But as here they have given a clear-cut instruction that urine for methyl malonyl CoA, that is MMA, methylmalonic aciduria, is seen, so it is going to be due to cobalamin deficiency. We have discussed that pathway, that how it was elevated. Just a quick recap for all of you. In the conversion of this gentleman homocysteine to this guy methionine, we had talked about that methionine synthase was the enzyme, methionine synthase, and we all know this methionine synthase enzyme is actually dependent on which vitamin? Vitamin B12. We have talked about that bye-bye reaction, folate trap, how it is done, and if this is not possible beta, then homocysteine will rise and ultimately it will lead to homocystinuria. And why methylmalonic acidemia? Because we have discussed that propionyl CoA to succinyl CoA, in that conversion there is an enzyme called as methylmalonyl CoA mutase that is dependent on vitamin B12. If that is deficient, then L-methylmalonyl CoA will be elevated, that will be escaping out in the blood, causing acidemia first, then further causing aciduria, methylmalonic aciduria. Please try to make a note of this beta, important point that we have to make a call over here, right? Homocystinuria. My dear friends, the word always in our life is this. The word in our life is always this. Without this, we cannot achieve anything. We need to follow only one course now until we reach our success. Now your goal is to just go and hit the exam and get the knowledge out from the brain and try to utilize in solving the MCQs. And ultimately, my dear friends, success is just waiting around the corner. You have to just go grab and catch it. That's all. Focus, follow one course until success. Question number 21. What is this question? These are easy, straightforward questions just to boost you up, your morale high beta, so that quickly this question. Thank you so much. Yes, the answer is definitely baby over here. The answer is B. As we can see, multiple positive findings are given over here. You cannot miss this diagnosis beta, that sedentary lifestyle, OPD, palmoplantar pigmentation, zone of calcification on the intervertebral disc, Benedict's reagent, greenish brownish precipitated, exactly from the notes. This is how the question has come. Please remember, on performing Benedict test, this is the color change that we are going to see. Here it will not give you that exact color what we see in case of Benedict test, that is that greenish, then orangish, then reddish, then brick reddish. No, rather here we get a mixture of green and orange and red together, like little bit like a brownish type of shade. This is the important point that we have to make a note over here beta. In case of alkaptonuria, whenever we are performing Benedict test, This is the color of the urine sample that we are expected to see. Please try to make an extra note about this one. It is a case of alkaptonuria. Zone of calcification over the intervertebral disc, ochronosis of the intervertebral cartilages. This can make a pain while bending forward. While bending forward, there is a pain. सामने झुकते हुए पेन आता है, बाबा रे बाबा, इसको हम लोग एल्काप्टोन्यूरिया सोच सकते हैं. यस, पेन while bending forward. Please remember ochronosis of the our pinna of ear, ochronosis of the palm. This is called as palmoplantar pigmentation. Mainly it is seen around the lower and as well as the side. It can also be seen around the sides as well. It can be, but central zone is usually spared. Central zone में नहीं होता है. Central zone is actually spared over here. The changes are actually over this. This is the pattern in which the palmoplantar pigmentation is mainly seen. Please try to remember this important point better, right? Palmoplantar pigmentation, ochronosis, one of the hallmark finding. Okay, what is this? What is this? From the image, whenever there is an image in an MCQ, it is a benefit, it is an help, but sometimes it can be bouncer. Diagnosis, please. एक काम करो, सब मेरे पास आ जाओ, गोवा चलते हैं, उधर समुद्र में डूब के मरते हैं. रीड द क्वेश्चन प्लीज. ये कैसे गलत हो गया? अरे बाबा रे बाबा रे बाबा. नहीं रे, ओ माय गॉड. Answer of this question, my dear friend, is this. Answer of this question is this. Class में बोला. During the class, I had shown you this Cazals necklace image and I told you it can be used in 4 different scenarios. These are the 4 different scenarios. How to differentiate that? How to differentiate that? Dermatitis, diarrhea, dementia, maize eater, sorghum eaters, B3 deficiency. Then we can choose the answer of B3 deficiency. Here, they have given a clear-cut hint. चीख चीख के बोल रहा है. Urine investigation, high xanthuranic acid. Xanthuranic acid urea is a marker for B6 deficiency. ये गलत कैसे हुआ? Xanthuranic acid. Those of you who are thinking heart nap पे होता है foul smelling stool, indicanuria, transporter defect, वो सब हिस्ट्री दिया हुआ होगा. Malignant carcinoid syndrome can present with this. Diarrhea will be there, flushing will be there, pellagra like symptoms will be there, 5-HIA will be increased in the urine. We have discussed this same image in 4 different scenarios. Answer of this particular question is going to be xanthuranic acid. Xanthuranic acid urea, it is a marker of B6 deficiency. Instead of giving xanthuranic acid urea, they can also give a extra hint that the patient is also having sideroblastic anemia with Cazals necklace, B6 deficiency. They can also give you another hint, RBC transaminase activity will be decreased. Answer will again go for B6 deficiency. This sort of things, answer goes for B6 deficiency. B6 के साथ xanthuranic acid urea, वो जो येलो कलर वाला पाथवे था, पीला, नीला, hara, yellow, blue, green. In that pathway, we wrote in the yellow colored pathway B6 deficiency. Xanthuronic aciduria is the marker. बेटा ये गलत नहीं होना चाहिए था. पूरा क्वेश्चन पढ़ना है, प्लीज रिमेंबर. इसमें फाउल स्मेलिंग स्टूल होता है, हार्ट नर्व, इंडिक एन्यूरिया, लाइट ब्लू कलर यूरिन, ट्रांसपोर्टर डिफेक्ट, ये सब चीज बोलेगा. पुट्रीफैक्शन हिस्ट्री देगा. malignant carcinoid, they will try to give you a history of argentophenoma. B3 deficiency will be straightforward. Maize eaters. Also I told you glove stalk lesions, glove stalk paresthesia nahi re, glove stalk lesions. You can go for direct B3 deficiency as the hint, but B6 deficiency, these are the hint. We have to keep it in our mind. Right answer. Thank you so much. Right answer. Galactose 1-phosphate. Yes. Very good answer. Very good answer. Question थोड़ा tricky है. Direct galactosemia question नहीं पूछा है. They have not asked directly like the conventional galactosemia question with the clinical features and all. They have given already the hint that it is a case of galactosemia only. Galactose is elevated, galactitol also elevated. Please remember, in order to determine the enzyme that might be defective, which enzyme defect is the question, that for that which metabolite should be measured. कौन सा एंजाइम का डेफिशिएंसी है, ये कैसे मालूम पड़ेगा, किस पैरामीटर को देखेंगे तो मालूम पड़ जाएगा, ये क्वेश्चन है. Please try to understand. In case of galactosemia, we have talked about classical, non-classical, plain, straightforward. Classical galactosemia, there is a deficiency of which enzyme? Galactose 1-phosphate uryl transferase. इसका दूसरा नाम था Galliput, Gal1-put. And what is the galactokinase? Non-classical. If this non-classical is deficient, then it is galactokinase. But how do we determine? By looking at the metabolic product. The answer over here is galactose 1-phosphate. Galactose 1-phosphate. कैसे? क्यों? देखो, समझ लो थोड़ा सा. Try to understand. Make your concept very strong. If you go for estimation of the galactose 1-phosphate, please remember, if it is due to non-classical galactosemia, in this case, the galactose 1-phosphate concentration will be very, 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 very low. Because the first reaction will not take place and galactose 1-phosphate will not be formed in the first place. But if it is a case of classical galactosemia, then this galactose 1-phosphate will be very, 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 very high, due to which there was refusal to suck breastfeed, pot belly, hepatomegaly, UGT inhibition, unconjugated hyperbilirubinemia, all those things were seen due to this dangerous compound known as galactose 1-phosphate. So if you estimate the single guy, you will be able to know whether it is due to this enzyme or it is to this enzyme. Enzyme assays are always costly. We have poor patients in the hospital. They can't afford enzyme assay of this. That's the reason in India most of the time, whether it is due to classical or non-classical, ये समझने के लिए we don't go for enzyme assay. Rather, we basically go for estimation of galactose 1-phosphate. Estimation. We go for liver biopsy, we go for galactose 1-phosphate estimation. If it is low, but features of galactosemia are there, non-classical type. If it is high, go for classical galactosemia. Please try to make a note of this. This is the guy I told you is the most crucial guy in case of galactosemia topic. Please remember this. Galactose 1-phosphate. Important point. Last two questions. I want right answer. बाप रे, ये सब क्या है? This questions that I have given to you, you need to apply your common sense as well as the concepts and the content of the notes. Common sense भी काफी important है यहाँ पर बेटा. Okay. Great. Yes, yes. Thank you so much. Thank you so much. Thank you so much. Right answer. Right answer. Right answer. Right answer. Right answer. Right answer. Basically, yes, so much of history is there. Self injection, forgot, stat glucose found to 45. The blood glucose was so low because which one of the following tissue assimilated most of it under this condition? Insulin. Please try to understand, my dear friends. Afterwards rush to, but then forgot to eat. That means insulin load is given. Insulin is in love with number 4. Insulin loves number 4. Glut 4. Insulin activates glut number 4. Glut number 4 is present in what? Skeletal muscle, cardiac muscle, adipose tissue and lactating mammary gland. So out of this, adipose tissue is going to utilize all this under this condition because the insulin load was already given, but the glucose load was not given because he forgot to snack or forgot to eat. Straightforward question. Glut number 4. Please make a note of this. Last question of our session. Hope all of you give me the right answer. This question, simple question, my dear friends, with which we will finish it off. बारिश आ गया. अरे बाप रे बाप, खत्म करके ही बाहर जाऊंगा मैं. सिंपल क्वेश्चन, रिपीट क्वेश्चन. अरे बाबा रे बाबा रे बाबा, ओ माय गॉड. भाई क्वेश्चन को पढ़ो ना प्लीज. डोंट गो फॉर सिली मिस्टेक्स लाइक दिस इन द एग्जाम डे. अरे ए नहीं है, ए ए ए मतलब आ ओ आ नहीं है. ओ माय गॉड, नो 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 नो. अरे नहीं रे. कौन है ये? पूजा, थैंक यू सो मच. धनश्री, थैंक यू सो मच. शलभ, अभी आया लाइन पे. ओके, द आंसर ऑफ दिस क्वेश्चन माय डियर फ्रेंड इज एलडीएल रिसेप्टर्स. ओ माय गॉड, इट इज a case of what? Type 2A. It is a case of what? Type 2A. Primary familial hypercholesterolemia. Cholesterol level so high. Look for this. Routine check. Father died. Positive family history. Elder brother or father died. Please try to understand. Positive family history. Greatly cholesterol through his life. Physician lovastatin. And तुम लोगों ने स्टैटिन देख के HMG को रिडक्टेस मार्क कर दिया. यार क्वेश्चन को कौन पढ़ेगा यार? अरे यार, लोवास्टेटिन देख के कहीं पे निगाह है, कहीं पे निशाना. सही जगह पे देखना इंपॉर्टेंट होता है लाइफ में. यही तो हम लोगों ने सीखा बायोकेमिस्ट्री में. सही जगह पर देखना होता है. ओके, लोवास एंड इज कोलेस्ट्रॉल लेवल ड्रॉप टू 170. ओके, लोवास्टेटिन क्वेश्चन ये नहीं पूछा. दे डिड नॉट आस्क लोवास्टेटिन हैज इनहिबिटेड व्हिच एंजाइम. नो, the nature of the elevated cholesterol in this patient is most likely due to mutation in which one of the following? That is due to LDL receptor defect, primary familial hypercholesterolemia. cholesterol high, triglyceride low, autosomal dominant, runs in families, most common type of hyperlipoproteinemia in India, corneal arcaxanthelasma, atherosclerotic plaque in aorta, tendon xanthoma, knuckle xanthoma, all those that we have discussed in the hyperlipoproteinemia topic. HMG co-reductase is not the answer. Lysosomal acid lipase deficiency leads to Wolman disease. Wolman disease. Lipoprotein lipase deficiency leads to type 1 hyperlipoproteinemia. उसको भी लिख देते हैं. This deficiency leads to Wolman disease. Lipoprotein lipase deficiency lead to type 1, that is chylomicron syndrome, that is known as chylomicron syndrome, right? These are the MCQs, my dear friend, that I wanted to discuss with you. Thank you for this 2.5 hour session with me. I hope some silly mistake that you might have done on the exam day, you will not repeat it again on the exam day. That is the main whole and sole purpose of having these sessions, to make you familiar with the pattern of MCQs which are being asked nowadays and the silly mistake that you might do. So my sincere request to all of you on that exam day to read the question carefully. Enough time will be there, and please choose the correct answer and do not change the answer. Do not change the answer. Better. Wish you all the best for your upcoming preparation, and I hope that you also enjoy the upcoming 25 most important sessions organized by MIST. And thank you so much from the bottom of my heart, and wish you all the best. And my dear friend, from the entire team of MIST, we are praying for your well-being, and एकदम फाड़ के आएंगे एग्जाम में, एकदम फाड़ देंगे उन लोगों का. And may each and every one of you pass, because each and every one of you have given your best possible effort to conquer the impossible. But remember, it is going to be I am possible once the results are out. Thank you so much, and good night to all of you. Beta, love you all. Thank you so much. Beta, thank you so much. Last question, please remember, repeating the last question one more time, beta. Please remember, here the question is, elevated cholesterol in this patient is due to the mutation in which one of the following? See, primary familial hypercholesterolemia is due to the defect of LDL receptor. LDL receptors, which are supposed to be present at the peripheral tissues, are absent. Liver is making cholesterol. It is taken up by the LDL, because all of you know LDL carries the cholesterol from liver to the peripheral tissue. Liver is sending all the cholesterol through LDL, but the receptors at the peripheral tissue level, which are supposed to be able to capture the cholesterol from the LDL, receptors are absent. It is a gene mutation due to which LDL receptors are no longer present. That's why the plasma will have huge amount of the LDL, huge amount of the cholesterol level, and the patients are having massive chances of atherosclerosis, and they die faster. Autosomal dominant, runs in families. If their father had died at the age of 42, this guy probably will be dying much more earlier than his father's age at which he had died. Please remember, runs in families, primary familial hypercholesterolemia. Most common type of hypercholesterolemia or hyperlipidemia or hyperlipoproteinemia in India is this type 2A PFH. Please read about Frederickson-Levy-Lees classification. Total 6 types of disorders are there in that. Thank you so much. God bless you and wish you all the very, very best, beta. Thank you so much, beta.